the advancements towards extracorporeal circuitry, of truly going ahead and modifying that greatly. So we probably started out in the early 90s of making advancements of talking about condensing the circuit, which is why this topic today is going to be was so attractive to us when we first started our research 5 years ago. So in 1998, we put out a publication called the MAST system. So MAST is an acronym for Minimized Area Surface Modified Technology, where we went into the lab, we had solidified a grant. And the first ideas of that when we were competing with off-pump surgery is truly thinking about we needed to do something better. I had a surgeon that I had worked with who kept telling me that you may want to go teach full-time in medical school because what you're doing may become obsolete. And so we jumped on that tremendously. As you can imagine, a low funding grant to analyze off those manifolds is costly. So we went through that money quickly, filed again for more money, and got through and came up with the first generation for that condensed circuitry. We never used the term miniaturization. We've never miniaturized anything. We've used the products of the major manufacturers, and we've altered the pathway. From that publication, we then went ahead and developed the Pinnacle system. Pinnacle system configuration with a open or closed system, and with an air removal device, and truly then making the big leap, because the limiting factor for us as perfusionists has always been the hardware. So we put everything on a telescopic pole, got it closer to the field, and basically obliterated the tubing. So we got down to, in our latest publications, you know, our circuitry, we use nothing, although where I'm sitting now, I just came out of a case, we do nothing but adult surgery here, but we use nothing but pediatric hardware. So we have a prime of, pretty much our static prime is about 520 ml. So even in those patients who are hemodynamically unstable, in essence, that prime every day is a zero prime. So which led to a lot of our research in cerebral oximetry, showing that all over the world, when you initiate, you're probably 25% off your baseline numbers. Here, our numbers initially will rise. So those were big leaps. So as you can imagine, as being at the podium and doing all this research and modifying the extracorporeal circuitry, when this idea of going back to single dose techniques and adding that volume into the circuitry, we decided that we would go ahead and look at this closely. So we're not going to get to all the projects that we did, but I've kind of picked out 3 or 4 that we really want to highlight and tell a story here. So how we've looked at this, we're going to start with our cell culture model, how everything, you know, that's where we go, given our laboratories. We start with an investigation and setting up a cell culture model and looking at it in the laboratory before we take it over to the clinical phase. So I'll stop with that. Let's get started here. So we have no conflict of interest or financial arrangements associated with this presentation. All of our research is our own. We are not funded by any outside companies. So here's an outline for what we want to discuss today. There is, like I said, there is a lot. So I want to talk about the concept of myocardial protection. So that will be a review, and we'll touch a little bit on the history. Then we'll discuss single dose solutions, then recent research briefly, but we want to talk about our projects, our experimental, our clinical, and how we do follow up these people long term. And we do that with nuclear imaging. So whenever we start on a project, right, you do a literature search and see what you have. So up until February of 2020, cardiac surgery, there's over 400,000 publications on cardiac surgery. There's almost a little bit over 20,000 on protection and preservation. Those terms are synonymous with each other. And cardioplegia. Very few on pediatric, right? And it's interesting, right? Cardioplegia was developed for congenital pediatric surgery, and there's few publications with that. So it's interesting when we're looking at this and doing the literature research, and although the second half of this is going to be into blood management, when we've done some webinars since this COVID started, we've done a series of webinars in our blood management program, and we look at outcome measures for blood management. Well, that you can go into, pull the data, blood in, blood out. And when we look at, for cardioplegia, you know, there's this contradiction. So we look at outcome measures following how much blood is given to a patient. We can record all those outcomes, and we can measure troponin levels for outcome measures on the cardioplegic side. But systematic review, when you investigate systematic review on the blood management side, there's numerous. And on the cardioplegic side, there's very few. What you get into when we start to investigate guidelines, I mean, for blood management, it's quite ubiquitous. And although literature on the cardioplegic side, literature is voluminous, but as far as guidelines, we have nothing. So almost 70 years into this, we still are varied on that. And it's interesting because Dwight Magoon, who's a prominent surgeon for years at the Mayo Clinic, actually, when he was the editor for the Journal of Cardiothoracic and Vascular Surgery in 1984, he published a full edition on a symposium that was given specific for cardioplegia. That was unprecedented. And then the editor, 4 years after, did the same, actually published in 1988, did a whole volume given to the group at UCLA on all their research. So those types of things were unprecedented in that. So when we talk about myocardial protection, talk about some of the complications in pathology. So those complications are going to be ischemic injury and reperfusion injury. So if we look at what those complex interrelated pathologies may be, there's from inflammatory upregulation, we can have free radical generation, toxic oxygen species, there's calcium imbalance, what we're going to get into. I want to talk a little bit about that. We have a lot of students on this. We have medical residents that are linking into this, so I want to cover that. There's disruption of the cell membranes, there's iconic ionic disturbances, and endothelial damage to blood cells, which we're really going to talk about and from our research. So then the reperfusion injury occurs, and that's the injury that's caused above the ischemia itself. So again, there's those ionic disturbances, but then you have calcium-oxygen paradoxes. So the calcium paradox is, we're going to cover that here, is when we have constriction, stone heart. And the oxygen paradox is something that's been investigated, and there is a fair amount of literature on that, is that, when we have a period of ischemia, and then we go ahead and reperfuse that injury, and we hyperoxygenate, we actually further that injury. So that has been documented. So again, we mentioned in the literature search, myocardial preservation and myocardial protection, those terms are synonymous. And it wasn't until probably 1955 when we actually had a true definition for cardioplegia. And in that, we want to limit the iatrogenic injury, and that's associated with conducting cardiopulmonary bypass. This is probably maybe one of the most important slides in this presentation, because we're going to talk with the surgeon. The surgeon's going to figure out the delivery technique. They're going to figure out the chemicals that are going to go into that. That pretty much comes from where they were trained. That doesn't change too much. When we had a perfusion school down in New York, I sent the students out 1 year to 24 centers to do a survey about cardioplegia. We came back with 43 different cocktails. So inside one, now there was probably one institution that was running 4 different cocktails in that. So this does vary. So the physical conditions, the temperature, we had spent 3 to 4 years of our time publishing about warm perfusate, warm cardioplegia. We actually presented at many, many meetings about that. So it can be done. It results, our findings were very well. So hypothermia, but the big key here is the fluid dynamics, and especially relating to the single dose cardioplegia. So we were just talking about this all this week, how we have new perfusion students here. And this is such a critical component of the single dose cardioplegic, because if this isn't done right and you're gonna run this length of time, the delivery is of utmost importance. We as perfusionists know. So we've taken our clamps off, we've started blood flow through this glorified shunt that we have, and the rocket is starting to leave the pad. But now it becomes the critical component is how we're actually going to deliver that. I had a phone call last week, one into Monday of this week, of some situations where they were delivering a single dose solution. It was a 300 ml, heart arrested nicely. And then the surgeon felt to move ahead with the operation. But there was a conversation about the time frame of what the delivery should have been. So there was an incident of the perfusionists backing off on the flow rate. So the aorta became flaccid and there was an LV bent in. So I think the surgeon lost track of where they were, and there was not a full delivery. So this is so critical of an importance is that, you know, when we teach the students how to do cardioplegic delivery, I put my hand over their hand, I hold it, and we truly have to shut that valve, close that aortic valve, and get it closed, because the time interval, again, before you redose is going to be critical. So at the bottom here, I put all these snippets, which are really found in almost every paper in cardioplegia. So inadequate myocardial protection. Inadequate myocardial protection is a primary causative factor of cardiomechanical assist, and Zaroff wrote that in CHEST. So we have, when we talk about chemical action potential, there's the intracellular formulation, high potassium, and extracellular formulation. This probably goes back, you know, what side of the Atlantic you're standing on. If you're standing on over the pond in Europe, more of an intracellular formulation. Here in the States was an extra formulation. But really, when we're giving cardioplegia, the nursing terms that we've come up with is that, you know, the action potential, you want to raise that action potential from minus 80 millivolts to minus 60. And that makes the myocyte refractory to electrical stimuli, where we have an arrest. And by doing that, we'll know we're going to lower our myocardial energy needs, reduce the myocardial oxygen consumption, improve cell's ability to withstand ischemia. So with that being done, if we, you know, we've always talked about this, is that just by emptying and arresting that heart, we reduce that MVO2 by 95%. So are we just, with all the things that we do, right? So this slide here of all the chemical additives, with everything that's in our armamentarium to offer to arrest these hearts, are we chasing that 5% window, and we can get away with a lot of things. So we look at what's in these solutions. We have lidocaine, adenosine, magnesium, all anti-arrhythmics. Lidocaine being a class 1B antiarrhythmic. And then in the mid-'80s, we started to see aspartate glutamates. But every one of us is familiar with one of these solutions. And, you know, when we first started, you know, serendipitously, when we talk about salt solutions and plasmolite, it was Sidney Ringers in his lab in 1982. He had a new distill system put in his lab. And then the lab technician was filling the bottles for them to do the research. They were doing the research on canine and frog animals. And when they started to revive these frog hearts, you could see that the contraction was coming back greater, and they were figuring what had happened. But what had happened is the distillery broke down, and the technician was refilling the bottles with tap water, and tap water contained calcium and magnesium. So serendipitously, they actually fell into Ringer's solution. So at the bottom here is another snippet when we talk about inadequate myocardial protection. So we lack the uniformity in myocardial protection techniques may have occurred because the choice of cardioplegia solution is not as important as the technique of administration. So Demi published that in 1994. So the delivery and how we deliver it, utmost importance. So I want to talk a little bit about the calcium paradox, a little bit of some biochemistry and physiology. And it's the overload in the cell and that fixed contraction, and brought in by the role of magnesium, and it's important movement of the calcium ions. So if we can just take a moment, just to, I got a couple of slides here, we can take a step back, and if we can look at the myofibrils within the myocyte sarcomeres and the myofibrils, and we can take a little bit closer look at the structure and the function. I want to briefly touch on the actinomyosin sarcomeres. So if we talk about the stretch, right, what is happening? So we look at the myocyte, a normal sarcomere, little bitty things, 1.8 to 2.0 microns. And it's when we overload and we preload these, and the max tension is 2.2. And we go beyond that, right, is that we start to rupture things. But the importance is the length-dependent activation is dependent upon the affinity for the calcium and that increased troponin. So we have the actinomyosin, the Z bands, and that contraction occurs by the animation in the cartoon that I had put down below. So when we talk about myosin, right, myosin is an abundance of these. Those are the heavyweights in this. There are about 470,000 dolphins. There's a bucket load of them of myosin. There's about 300 molecules. Each myosin has about 2 heads. And the importance there, it's going to hydrolyze the ATP, and that's going to be required for the actin and the myosin cross-bridge formation. So with this, there's the troponin complex, right? So we've learned in our past studies is that we're going to have troponin I, troponin C, troponin T, and that regular intervals to tropomyosin are going to be attached. So in troponin C, that's the binding site for the calcium. And I have built a small animated cartoon to show this a little bit further. And troponin T, that attaches into the tropomyosin. And the troponin I, that's where the conformational change in that complex is going to occur. So with the troponin I, it moves away from the myosin binding site on actin, thereby making it accessible, to be accessible to the myosin head. And the importance of the magnesium comes in where that relaxation occurs. And the myosin will then detach from the actin. So this is important. So the American Society of Physiology, a friend of mine, Peter Deltoum, who's a physiologist at the University of Illinois in Chicago, and he published this back in 2010 in the journal Biomechanics. And you think 10 years ago, he really had a handle on this. So if we look at the myosin, you can see the myosin section rod here, and the ATP is coming in. So this is a helix. So the actin tropomyosin is wound in here and the actin is on a helix. So this twisting has to occur. So this has to open for the ATP to come in and be hydrolyzed and conversion for the ATP. This is during diastole and systole. So if we look a little closer at this, so when we show up right here are the players that are there. So we have tropomyosin, here's the uractin helix, the myosin complex with the ATP activation, and I want to show you the tropom, hopefully this works. I'm going to show you here. So I'll have to run it a few times. So we're going to see that the calcium floats down, hits to the troponin, opens this helix. So there's a twisting that occurs. Opens that troponin. Once it touches into the helix, where the myosin complex with the ATPase activation occurs, that occurs. And what happens is this dagger coming in here is the magnesium, which resets it. So as we play this, typically I had it moving forward, but this is actually how it goes. So the twisting of the helix actually creates for that bridge to occur. So I put these up here to kind of take a step back now and just kind of emphasize for the fact that, you know, we're going to give cardioplegia, we're going to lay down this organ, an organ that's going to beat 3 billion times in an average life form. It's going to pump 210 million liters of fluid. And it's going to travel to 60,000 miles of our vasculature. So if you think you're just going to lay this organ down and not have any repercussions, we really need to look closer at this. So I just want to give one slide to acknowledge these gentlemen here. So right in the brief history let me go back here in the left-hand side, it's Dr. Bill Bigelow. He was a surgeon up in Manitoba, Canada. And when I was up in upstate New York, I actually saw one of these, it's almost canoe-like, where they would submerge the patient in ice and bring him down. And then Eke Seni in 52, he was doing a fibrillatory arrest, run and gun it, that was doing here. And then this famous guy is Dr. Nolan Shumway. And Shumway was on the Pacific coast, and in 1959, he actually figured out that, well, instead of cooling the whole body down, why don't we just go ahead and selectively isolate the organ, the heart. So he wrote a paper, Selective Hypothermia in a arrested anoxic heart. And in 1959, he had nowhere to publish that. So he actually published that in the Journal of OBGYN. And then here is famous Dr. Cooley, who would go ahead and was so fast at times that he could do intermittent ischemia or just go ahead and do a continuous. But what he then surely ran into is that calcium paradox where there was constriction of the heart, stone heart that occurred. And then we come into, into the, so the heyday, right, is when coronaries came into the 70s, and there's Dr. Brainbridge who created his St. Thomas solution. So in the 70s, so we had 74 Brainbridge in St. Thomas, 75 Hans Brennschneider, Custodiol today, started coming out, and in 78, Dr. Buckberg, who over at UCLA, knew him quite well, is a Bronx guy. I grew up in the Bronx, so did Dr. Buckberg. He came to visit us here. We had a couple of ventricular restoration symposiums, and he stayed here at the Wentworth Hotel in New Hampshire. And my last vision of him is leaving him on the porch as he had a cigar and a glass of scotch. So, so as we know of all his blood components added into the cardioplegia. So here, early on, Melrose, right, in the beginning of the history of this cardioplegia is the Melrose technique, is they were taking actually 25% potassium citrate put it in a syringe of 18 mLs of warm blood and put that into the aortic root and achieving arrest. If you've ever done laboratory studies with pigs and canines, this works very, very well. But what was found is that when they started to bring it into the OR and they were administering cold blood and 2.5% of tripotassium citrate, well, what they started to see is there's an extensive amount of myocardial necrosis which occurs with this technique. So that just went to the wayside. So, So we talk about now, we'll jump to single dose solutions. So we want to talk about the Del Nido solution, right? So is everyone familiar with these? So in a 1 liter bag of plasma-lyte, we have 20% mannitol, 16.3 mLs. Mannitol has the capabilities of both scavenging free radicals and reducing edema due to the hyperosmotic capabilities. Magnesium sulfate is in there because that blocks the calcium channels. And that's, it's been proven to improve myocardial recovery. And sodium bicarbonate is there because sodium bicarbonate will scavenge hydrogen ions and will maintain the intracellular pH for us. And potassium chloride that provides a rapid depolarization of depolarize the rest. And however, though, research associates depolarize the rest will slightly impair the myocardial recovery due to an intracellular sodium and the calcium accumulation. So that potassium concentration that Del Nido has been described about 26 MEQs. And lidocaine, you know, Dr. Del Nido describes this in his pediatric publications because lidocaine is a sodium channel blocker. It's a class 1B antiarrhythmic agent. It increases the monocyte refractory period. It prevents against the negative effect of the hyperkalemic depolarized arrest. And that's done by polarizing the cell to some degree and reducing that intracellular sodium and calcium influx. And, you know, Del Nido, by what is written, is the crystallite Del Nido solution is given about 20 volumes percent of a blood additive. So the idea behind that is reduces energy consumption, blocks calcium flux into the cell. It will scavenge those hydrogen ions. It will preserve the high energy phosphates. It's going to promote anaerobic glycolysis during myocardial arrest. But the big thing is that it doesn't keep the heart warm. I was just down at a major medical center. There were 4 rooms going, and nobody these days tends to monitor myocardial temperatures. So I took surgical fellows and another attending who went in. We asked the anesthesiologist attending that was in the room, or the fellow was in the room, and asked, can you tell us what the temperature of the heart was? And in each room, the temperature of the heart per the echo was no colder than 32 degrees. So, you know, as he describes it, it's a mixed 4-to-1 crystalloid with blood. So you give 20 mLs per kilo at 8 to 12 degrees centigrade, up to 50 kilos max, so 1,000 mLs. And you repeat that only for the clamp time. Now, in the literature, I put 2 there, 2 hours of our electrical activity. You know, what they describe as 3. But you have to remember is that Dr. Del Nido, you know, we have spoken with him at several of the meetings. I took a picture of Sirdar and Dr. Del Nido, Professor Ganade and Dr. Del Nido together, and we were having a discussion. And at no point does he advocate that this be utilized for adult surgery. So he's very concerned about this. And you have to remember is that every patient that he operates with this formula for pediatrics, he's cooling them all relatively to 22 degrees. So it was originally designed for pediatric use. There's no suggestion for the adult population. Here I put greater than 200 different modifications. We're beyond that. We're about 300 different modifications that we can do. Everybody is changing. Everywhere you go, everybody has a different cocktail to this. And we mentioned before, the lidocaine in this is pretty substantial. So we talk about HTK, right, with the histidine, ketoglutarate, and tryptophan, which is the custodial cocktail that's delivered. So custodial, it's an intracellular crystallite cardioplegic solution. And it's used by some centers for myocardial protection in complex cardiac surgery and organ preservation and transplant surgery. So the HTK is, you know, the old Brett Schneider solution, and custodial is attractive for cardiac surgeons because it's administered in a single dose, and it's claimed to offer myocardial protection for a period of up to 3 hours, allowing performance of complex procedures without interruption. So again, it's classified as intracellular crystallite cardioplegia due to its low sodium and its calcium content. So it's the sodium depletion of the extracellular space which causes that hyperpolarization of the monocyte plasma membrane, and that's inducing arrest during diastole. So this is a different mechanism of action for conventional extracellular cardioplegia solutions, which are high potassium and cause an arrest by that membrane depolarization. So the high histidine content buffers that acidosis, which is caused by the accumulation of those anaerobic metabolites during that long ischemic period. And the ketoglutarate is there because that really does improve the APT production during the reperfusion phase. And the tryptophan is there because that will stabilize the cell membrane and mannitol, decreases the cellular edema, and acts as a free radical scavenger. So when we do a listing of Delnito versus HCK, we found Delnito is a pediatric formula for immature hearts, low temperatures. HCK can be utilized for pediatrics or adults. Again, there's probably over 300 modifications of that. HCK is a single formula. There's satisfactory evidence in pediatric surgery, satisfactory evidence in adult surgery for the HTK. There's been both as coronary distribution, if given retrograde, there's hemodilution, transfusion. Those aren't concerns, we'll talk about that. The lidocaine dosing dilemma in the Delnito and the sodium dilemma, which is brought up for patients who are running the Custodiol. So there's conflicting data on the limited population that we've studied and those limited clinical parameters. There's no data on long-term effects in the Delnito and HTKs, but and the cost, there's a cost associated with this. So now we want to get into the good stuff. We want to talk about, right, over the past 5 years. It's longer than that. By the time we set up our laboratory research, we get to conducting the research, we publish the publications and get out there, it's probably a little bit longer. So you can see we go back and do another literature research, there's a surge in this, right? So now we've had this void from the 80s, and now all of a sudden old is new again. We're starting to see the change here. So in the new literature, there's the group down in Nashville wrote a paper, does the type of cardioplegic technique influence hemodilution and transfusion requirements in adult patients undergoing cardiac surgery. Well, you know, to their credit, they put a lot in here. So they were looking at, you know, cardioplegia loose percentage in over 16,000 patients. And so much when you talk about the hemodilution, they did not find, when they actually looked at blood usage, the Custodial group actually came back the lowest as far as giving blood with that. There was a fluctuation of what your starting crit was, not to your ending crit. There was no change in that. From your starting crit to your ending crit, those were all comparative in those study groups. But it did fluctuate throughout the case, but you almost were volume heavy and you had the ability to get back to that. So that was the positive. The interesting here is that when we looked at this, is that when we looked at CABG first, the AVR, MVR, and the urgent, for the AVR, there was a higher usage in these for the AVR and the MVR for Custodial. The real thing here is, I should have put another red box around this, is the urgent is 32%. So when there was an urgent case, pretty much people did reach for the HTK as far as for protection. Now, I put a lot in here. I just wanted to, not to toot our own horn, but I just wanted to go in this. The great thing about this publication of this paper is that the group in Nashville does a great job because they have a registry. We had published this paper. We'll talk about this. They have a registry. And what's available now is that there's a company in Plymouth, Michigan called Orem Clinical Analytics, right? And if you have a registry in what we're doing, collecting all your data points and being able to pull in that data and then go ahead and investigate what you're doing in each center and each larger groups if you have a consortium of care. But the Orem Clinical Group in Plymouth, they're actually taking high fidelity granular data and connecting it. And they're doing that with the usage of the Thales system. So they're connecting all of these monitors and systems within the OR and they're able to pull that together. So they're able to do that for you, is that they can set up these registries for you. So data is power and they can do that for you. So each time and I put this paper here because in doing this and trying to promote more research for people to get into, and students were always asked, you know, we open our doors for people to get involved. But having a registry in our own centers and the ability, we can go ahead and create, you know, the text that we have by this. But also, the great thing about this is I wanted to highlight too is that, you know, please do the research, contribute writings to our journals. This particular paper has been cited almost 1,200 times, so it really shows the value of the JACC journals and the perfusion journals. So current literature about the del nido and HTK, what's that telling us? So there's always equivalent and or better early outcomes better than conventional techniques in pediatric population, mostly equivalent and or better early outcome than conventional techniques in adult valve surgery. There's conflicting data on limited adult CABG population. I'm going to put one of our studies, show you one of our studies that we have in here, and no data on long-term outcome, but we have done that. So the questions that we would ask is which patients should we actually use these solutions on? Pediatric adults, which types of surgeries, and what are truly the outcomes in myocardial protection. So now I want to talk to you about our experimental testing. So when Professor Ganeda and I talked, and we still really wanted to get in and start investigating this, we set up a cell culture model. So it was a long-term protective effects of single multi-dose cardioplegic solution in the cell culture model. So we use three type of models. So we use L9, 29, which are myofibrils, and then we used H9C2, which are primary neonate cardiomyocytes. And also we use UVAC, human umbilical vein endothelial cells. So we cultured those cells, we seeded them, we incubated them, and then we analyzed them. And we seeded them in 96 well plates. We used MTT analysis, and we did 24 well plates, and then we went ahead and we put them on the microscope, and we stained them with acridine orange and propylian iodide. And we did that at different temperatures. So our aim to test these single-dose cardioplegic solutions, we wanted to investigate the cell viability and the cell integrity. And we would do this first time, demonstrate long-term myocardial protection. So with that, we have cell viability with respect to time until 48 hours, cell membrane integrity, functional evaluation for LDH. So we want to do a cytotoxicity test with that. And we also needed to underline the answers to the questions that are acting better on pediatric adult or myocardium itself. When we did the cell viability, we did use, I had a question about this MTT analysis. You can also do in the laboratory, you can do MTS analysis, but there's a reagent, there's a, the MTS takes away you adding the steps with the reagent. MTT analysis takes a little bit more time. So when you're really working with tetrazolium dyes, there's this, if you go to the MTS, there's a colorimetric interference that can occur. So we took the time and we stuck with the MTT analysis. So here you have is how we conducted the study. So we have our primary neonate cardiomyocytes, or human umbilical vein endothelial cells, or myofibrils. So we did our control group. We did our St. Thomas Plugosol, blood cardioplegia, HTK, and del nido. Here's how we went ahead and incubated them. We tested our times. We did a baseline at 34 degrees, 2 hours at 32, 6 hours at 36, 24 at 36, and 48 at 36. So here are our results. And we did viability studies, right? So in those myocardial cells, those L9 cell fibromyoblasts, you see at the 2 hour, everything relatively close. And then as time goes on, the viability starts to change in these cells. Del nido a little bit better in the HTK, but over a 24 and 48 period of time, you start to see a change in that viability. So here's our results from those cell culture models in those human umbilical vein endothelial cells culture, and 2 hours, 6 hours, 24. You can see the separation as in the long run. Now, this is where we predicted this, and this is what we found, right? In those pediatric, in those primary neonatal cardiomyocytes, in those H9C2 cell culture cells, is that here, del nido, the viability is right there with the HTK in those pediatric cells. But here, when we went ahead and did our DH levels and the HDL cytotoxicity levels, which is, a functional evaluation of that cell membrane integrity. So for the percent of cellular disintegration in the L929, that the HTK outperforms all the other ones that we've analyzed. So after we've done that and we examine that, we go ahead and take these cell samples and put them under the microscope. And with staining, we can use, so we use acridine orange and propylian iodide staining. And as you look at these here's our control. And if you look at this, so when you start to see red, those are non-viable cells. So Pledgisol did not perform well. Blood with the Pledgisol was worse. So the HTK and the Delnido were comparative. In the UVEC cells, again, here's our control, Pledgisol, blood Pledgisol, and you can see how vibrant in the endothelial cells, not much shedding compared in the adult cells in the HTK to the Delnido. And then here in those neonatal cardiomyocytes, at 24 hours, the viability was pretty good in all. So then we went ahead and we presented this at a meeting last year, and it was an extension of our cell culture model. So this study was the safety dilemma of long-term protection of Delnido, HCK quadriplegia, and minimally invasive valve surgery, right? So clinical impact of the microvascular integrity confirmed by our cell culture data. So this was a prospective cohort study, which we included high-risk patients, so your score, greater than 5, undergoing primary minimally invasive valve replacements, and they were receiving different quadriplegic solutions. So we did this over a full 1.5-year period. So group 1 was St. Thomas, Delnido, and HTK. So here are our findings here. We did a left ventricular punch biopsy specimen, and we collected that at the end of the CPB, and we did that in each case, and we processed that. So then what we have is serum syndicant 1 levels, which were measured by the ELISA via an arterial line before T1 and via coronary sinus sample at the end of the cardiopulmonary bypass. And T2, that was a solid phase monoclonal BB4 antibody, and that was against the extracellular domain of the immune syndicant. And we incubated these cells. We used a lipopolysaccharide solution in combination with a lipopolysaccharide binding protein, IL-1B, or with the GM 6001 in culture medium. And we used that with 2% fetal calf serum until 24 hours. We were routinely grown to 80 to 90% confluence. So we were trying to get at it, the EG shedding, right? The endothelial glycocalyx shedding until 24 hours was documented in microscopy. So the endothelial glycax, well, that's a type of identifier that the body uses to distinguish between its own healthy cells and the transplanted tissue. So the disease cells are the invading organism. So included in the glycocalyx are cell adhesion molecules, and that can enable the cells to adhere to each other and guide the movement of cells during embryonic development. So the glycocalyx will play a major role in the regulation of the endothelial vascular tissue, including the modulation of the red blood cells in the capillaries. So what were our results there? So each perioperative data demonstrated that all 3 types of the cardioplegic techniques provided effective clinical outcome with similar effects on blood biochemical parameters. Our cross clamp times were relatively the same, but there wasn't a significant difference among the group with respect to the demographic data, the BMI and the change in the troponin levels in T1 and T2. So when we look at these Syndecan 1 levels and the nanograms per ml for the St. Thomas, the Delnido, and the HTK, relatively close. And then we did the cell culture endothelial glycalyx shedding. So we went ahead then and did staining with the Syndecan 1 of that left ventricular biopsy punch that we did. And so here you can see if we work for the bottom. So unfortunately, the more vibrant the color, the more integrity we've lost in the cell. So you can see the bottom is the St. Thomas, here is our Delnido, and the upper is the HCK quadriplegia, so less shedding there. So, so the next study then, also in that same year, we did an impact on myocardial protection by single-dose cardioplegic technique on microvascular integrity, endothelial glycocalyx, and combined aortic valve surgery. And there's a deterioration of the endothelial glycalyx surface layer. And that's a new concept that we've associated with many disorders. So the damaged endothelial glycocalyx, that can cause a systemic and myocardial edema. You can also get platelet and leukocyte adhesion. You can get fluid extravasation, and that may result in a heterogeneity in microvascular perfusion. So that endothelial glycalyx shedding is accepted to be one of the earliest signs of adequate myocardial protection and may be clinically demonstrated by the serum syndecin-1 levels following the glycocalyx shedding. So syndecin-1, it will enter the circulation. The effects of the myocardial preservation methods on inflammatory processes, and that's been well documented. So the inflammatory response will correlate with the degree of the endothelial injury, and that may give an estimation of the protective safety of that. So with that, this prospective study included patients undergoing combined aortic valve replacement who received different cardioplegic solutions. We did that from 2015 to 2018, three separate cardioplegia formulas. In the syndecin-1 levels, we measured by ELESA via the arterial line and via the coronary sinus sample, the endocardial coronary bypass. We also did that right atrial specimen, but we collected that at the end of bypass and we processed that. And those cells that were incubated with the lipopolysaccharide solution in a culture media up until 24 hours. And you can see here, right? So picture is worth 1,000 words. So with the shedding that is occurring with our imaging, here's the custodial HCK and the del nido, it's pretty significant here in our findings. So with that, we had early perioperative data, and that demonstrated that all three types of cardioplegic techniques provided effective clinical outcomes with similar effects on blood biochemical parameters. So these numbers, and when we measured for T1 and T2 in nanograms per ml, are pretty similar here. There wasn't really a significant difference among the groups with respect to the demographic data, type of surgery, and the BMI. So here, when we did those right atrial punches, right, we put those under the microscope as well. We did those biopsy cell cultures of patients. So you can see that here's the del nido, and here's the St. Thomas. And you can see that there's really low levels here of the syndecin-1 in that HTK. So that was pretty revealing. So, so now, well, I'm just going to touch on one clinical data, and then I won't take any more time. So we went ahead and presented this other study that we did. So because we get this question about CABG patients, so we did perioperative comparison of HTK, del nido, St. Thomas, and cold blood cardioplegic protocols in patients with high-risk CABG. And there really wasn't a significant difference among these groups with respect to the demographic data, the BMI, and the change in the troponin T levels from before and after that cross-clamp. So these techniques provided an effective clinical outcome with similar effects of blood biochemical parameters in those adult patients who were going under CABG. So again, the patients that we chose and the methods to this was a prospective cohort study. It included high-risk patients, Euro score greater than 5, underscoring, and we wanted to compare oranges or apples to apples and not apples to oranges, and CABG times 4, and received different cardioplegic solutions. Utilized the St. Thomas del nido HCK blood cardioplegia. And what we did was different in this study is that, these patients were examined perioperatively by the memory loop recording. So we were able to look at these then on an order-triggered memory loop recording for 30 days via documentation of predefined symptomatic and asymptomatic events. So our early perioperative data demonstrated that all 4 types of cardioplegic techniques provided effective clinical outcome with similar effects on blood biochemical parameters in adult patients undergoing CABG. There wasn't really a significant difference among the groups with respect to demographic data, BMI, and change in those troponin levels before and after that cross-clamping time. So I think I've taken up far too much time. I'm going to stop there. And I think, Taylor, can we switch it over to Professor Ganadin? Professor Ganadin is going to take us through all the clinical research that we've done. We have a significant amount of volume there. So do I have to end sharing? Okay, great.
Okay. Hello. So good afternoon, everyone. This is Dr. Günaydin from Turkey. So it's 11 p.m. here, so it's a good night. Thank you very much for Essential Pharmaceuticals giving us this opportunity to present our data and to discuss our novel research on cardioplegia. I personally want to thank Mike, Dan, and Bill, and Taylor, of course, and my research partner, Kevin McCusker. So I will continue mostly on the clinical side of our recent research. And I'm working in this hospital, so this is one of the largest hospitals in Europe and in Turkey, of course. So we have about 4,000 beds and 131 operating rooms. We're doing more than 4,000 open heart cases and 25 to 30 heart transplants a year. So all kinds of surgery here. So when we start discussing cardioplegia, and when we look at recent data, so most of the research has been done over, especially in adult population. It was always done on blood cardioplegia. It was the most popular one until the recent 2 or 3 years. And then as you look at this data about 2015, so blood cardioplegia was the most popular one, but the single dose techniques were not that much popular at that time. So they became much popular after 2015-16, as they're becoming more fashionable to use in any type of adult surgery, including coronary artery bypass surgery. So let me just wrap up very briefly. HTK was introduced in about 1970s as a Breitschneider solution in Germany. And the main advantage is the buffering capacity of histidine. It's incredibly powerful buffer molecule. And then cataglycerate is an intermediary Krebs cycle component and acts as a very high energy ATP provider. It's a very strong energy source. And tryptophan is a kind of cell stabilizer, and also it's very strong. So also this solution includes mannitol as an osmotic diuretic. And the idea to stop and arrest cardiac activity is due to its intracellular sodium concentration of 15 millimoles per liter, and they become elevated and to very slight elevation of potassium. And then due to the buffer of histidine, only single dose is required. But of course, this solution lacks a kind of calcium. That means the longer time is required to initiate cardiac arrest. I will also underline this later. So when you're using HTK, the infusion time is very important. It should be over 5 minutes. So you should be patient to protect the heart very properly. And the needle was introduced in 1990s for the pediatric patients. And it's a kind of very diluted solution because 1-to-4 blood. And it composed largely of magnesium and mannitol and some lidocaine. And of course, it also doesn't have very much calcium. And it increases the cardiac arrest during surgery by decreasing the intracellular calcium and slow down the rate of energy consumption. So theoretically, it also reduces myocardial edema. But of course, and the disadvantage is that the use of Dalnido in adult population is still lacking of randomized clinical trials or safety trials. So we have many, since they become popular in the last 2-3 years, we see many different systematic review and meta-analysis on these single-dose techniques. So for example, in this meta-analysis in 2017, it shows that Dalnido works well in routine case, but it's not better than the conventional cardioplegia, but it's a non-inferiority study. And then we see a single versus multi-dose cardioplegia in adult cardiac surgery, again a meta-analysis, in more than 5,000 patients. And then they compare and they say, okay, and you see here, this side is for the conventional techniques and this side for single-dose techniques. As you see, most of the positive findings are on the contrary side. And when we see another systematic review and meta-analysis with Dalnido versus conventional cardioplegia in adult cardiac surgery, there are some, of course, less duration of cross-clamping, but the high-quality prospective data still is needed at the end of all those meta-analysis. The only thing to compare in the literature, Brett Schneider versus Del Nido for cabbage patients, the conclusion is very important. They say this should be used in low-risk patients. So, but now, of course, in our clinical practice, we always use these techniques in high-risk patients on the contrary. So why? I'm going to talk all about them. So when we review all the current literature, okay, single-dose techniques works well in, for example, let's say a simple cabbage case. And then it's not better, but of course the time is very important and redosing is very important that we'll be discussing later. So what kind of people are using what kind of cardioplegia? It's always different all over the world. This is a survey from June 2015 up to May 2016. A total of 923 responses were analyzed from Europe, North America, South America, Australia, and New Zealand. And then as you see here, don't forget, it's 2015 again. In Europe, for example, Del Nido use is 0 in adult population in 2015. And now it's becoming more and more popular in Europe also. In North America, the most popular one is, this is for transplantation, but for St. Thomas is the most popular one, and Del Nido is 23. So now they are becoming more and more popular. Kevin also showed this one. In especially minimally invasive cases, single-dose techniques are the just very much important preference. So, but this were all about yesterday. So this is a very important philosopher of Turkey, Rumi, and is so famous in all over the world. He says everything about yesterday has gone with yesterday. Today, so we're using single-dose techniques, so we need to say new things. And my presentation will be based on questions and answers. So first question, which single-dose technique for which patient? So as we show the cellular data, as you can see here, this is adult cell lines. So this is HTK, this is Del Nido. As you see, as the time goes on, so Del Nido protects the heart up to some point and then cannot go in a prolonged way. But HTK is very safe until 2 days in the cell culture. And this is for neonatal cell lines. They both look very much same in the pediatric practice because the temperature is another issue, so we'll discuss it later. And then question 2, which single-dose technique is better in long-term protection? So there are many, many papers, but they all review the only time duration inside hospital, so in hospital data, we don't have any idea in the postoperative period or late postoperative period. So we compared 3 different groups with Del Nido, HTK, and blood cardioplegia. And they were monitored thoroughly up to 1 month. So we were using this iPhone-like device. When the patients were discharged, they were connecting to this device. And this records everything for 1 month. And this data was collected in a kind of very specific setup. And we had the data sheet like this. So everything was recorded. Any kind of heart blocks, pauses, ectopic rhythms, atrial fibrillation, ST segment elevations, tachycardia, angina. And there's a button here. When the patient feels like uncomfortable, he or she presses the button, and then we have an SMS message and we call them, what's the problem? So we recorded everything up to 1 month to compare 3 different cardioplegic groups. So before the operation, there was not any difference, no demographic differences. And then we also measured some kind of very specific biochemical markers. So for interleukin levels, to show us the sensitive kind of sign of inflammation, as you see at the end of cardiopulmonary bypass, the Del Nido group has more interleukin levels that shows us more inflammatory response. Syndecan levels are the markers of glycocalyx, very early indicator of the organ dysfunction. And again, in this group, Del Nido has more syndecan 1 level. That means more glycocalyx degradation. So it means a kind of prediction for a long-term insufficiency of the heart. And this is what we done during the operations. And we always do use cardioplegia because they are long operations and with concomitant surgery. So we don't see any differences in these 2 groups for the cardioplegia volume, but in blood cardioplegia, we always give the blood cardioplegia every 20 minutes. So that means a higher volume then. And this is the data at the end of 1 month. As you see, the Alnido group, HDK group, and blood cardioplegia group, atrial fibrillation incidence is significantly higher in the Alnido in 1 month, 19 patients to 13, and 10 permanent atrial fibrillations to 5 permanent atrial fibrillations and 3 in blood. And in total events, that means the patient pressed on the button, or we recorded like tachycardia, bradycardia, ectopic victims, or whatever. So it's 83 events and versus 70 events and 78 events. So this was significantly worse for the Alnido and blood cardioplegia groups. And rehospitalization rate was nearly 2 times more than HDK and blood cardioplegia for the Alnido. As in the graph, to understand maybe better, so tachycardia was significantly higher in the Alnido group. AFib incidence was higher up to 1 month, and rehospitalization rate was higher up to 1 month. So as a conclusion, we say, okay, in the in-hospital data, there is not any significant difference clinically in between any groups of cardioplegic solutions. But in the long term, in 1 month, the Alnido has some kind of rhythm problems, especially AFib incidence is much higher. Then most of the rehospitalizations are regarded to this AFib incidence in the long term. And question 3. Those single dose techniques cause significant hemodilution because this is the main debate. When you give 2 liters continuously in, like, say, 5 to 6 minutes, you're causing hemodilution, or do you? So we organized, again, a kind of research because there were some papers that showing the hemodilution effects of these single dose techniques. So again, we completed 4 different groups in patients going to adult valve surgery. So more than 250 patients in each group in 4 years. And the endpoint was the transfusion rate and hematocrit change. But we were having a very specific protocol. We were using ultrafiltration for all patients until the hematocrit will reach around 25%. So we do ultrafiltration, and we ultrafiltrate, for example, in St. Thomas group up to 1 liter, blood 780, the Alnido more than 1 liter, and Custodiol more than 1 liter. So when you do this, there's not any very important differences. Maybe the inotropic agents were significantly higher in St. Thomas group, but not many significant differences in the early post-operative in-hospital data. And how about hematocrit change? If you use ultrafiltration, hematocrit change is very slight during the pump and then going back to normal before discharge. So there is not any significant difference with respect to hemodilution if you use ultrafiltration in those patients. And question 4, is acute hyponatremia following HDK clinically significant, or do we need to correct this hyponatremia? Because we see some papers reporting hyponatremia after HDK infusion that may cause to some neurologic problems. We never ever seen any hyponatremic level that needs correction in our clinical practice. But the most important point is not the sodium level. It's the most important one is the osmolarity level, because this will influence the balance of the patient after the operation, including the neurological balance. So there is now a very good paper, very good study that was published very soon, recently. So the name is acute isotonic hyponatremia after single dose histidine tryptophan catecholated cardioplegia and observation study. So in this study, they just have some blood samples from the patients going to surgery with HDK cardioplegia. So baseline, after the infusion, 10 minutes, 6 hours, 12 hours, 18 hours. And you see this different type spectrum of surgery, CABG, AVR, mitral valve surgery, and whatever. So they check for the sodium levels, but plus osmolarity. This is the data. So as you see, this is the sodium level. Yes, when you infuse, let's say 2 liters of HDK, sodium levels are dropping down, but recovers very quickly by itself with no correction. So this is the graph. So it becomes very much normal after some time after infusion, but osmolarity never drops. Why? Because of the amino acid content, HDK content of the solution. So it's always stable. So yes, sodium may drop down. You don't need to correct. It will recover by itself within some safe time. So I don't recommend any kind of correction. I also perform LA venting to take this extra volume out of the heart when I'm using it for the adult cardiac surgery. And of course, as I've told you before, ultrafiltration is important to become safe for the sodium problem. Question, redosing. This is the hot topic now, especially for Del Nido. What is the safest time to redose? So as you know, when Del Nido becomes very much popular, the suggested time was to, of course, you may say another one, but let's say majority of the suggestions were up to 90 minutes, 90 minutes. So after 90 minutes, it was suggested to redose for the Del Nido solution. But after, it becomes popular, researchers understand 90 minutes was not very much safe, so it drops down to 75, 60, and I have surgeons, I know they use 50 minutes. But for HDK, it's still stable to use up to 2 hours, but I always choose 90 minutes, 1.5 hours. So we also studied this fact to understand why and what is the safest redosing time for Del Nido and HDK. So we have now two different groups, Del Nido and HDK. And this is a minimally invasive surgery, but AVR plus something. So it's a long operation because we chose the patients with the longest cross-clamp times to understand the effects of redosing. So they have always some concomitant surgery, but it's also a challenging operation, minimally invasive aortic valve surgery. And we also have some subgroups. We also separated the groups that need redosing for Del Nido and HDK. We have now 4 groups. Del Nido, HDK, plus redosing. So we now measured aquaporins. These are very sensitive molecules inside the cell membrane. These are the molecules that are controlling the handling of water coming into the cell. So when there is an excessive volume, the cell synthesis aquaporins to handle this, manage this coming excessive volume. And when the cell capacity is over, it cannot produce new aquaporins and the cell fails and that causes cellular edema. So when we have aquaporin levels that should increase in the early period to manage this over volume, but if the capacity is over, then the aquaporin levels will go down. So this is the theoretical information, and we measured aquaporin levels all over those patients. So this is the demographic data before surgery, not any differences. And this is what we done. Aortic valve replacement for every case, of course, but plus aortic arch surgery, some concomitant CABG surgery, even tricuspid valve surgery. So these two are only single dose, up to 90 minutes of cross-clamp, and these are plus over 90 minutes, so we need to redose them. So when you just check for the clinical outcome, for the first time, we are seeing significant differences because, as I told you, in all of the previous studies, in the in-hospital data, in early postoperative period, we never have any significant difference in between cardioplegic groups. But now, in the redosing group, we have. So as you see, AFib was 6 to 3. AB block was 7 to 1. But of course, the patient population is low because we studied more than 100 patients, but only 30 of them needs a redosing. So, but even in these 30 patients, we have significant differences. So this is also important. And even ICU stay is nearly 2 times more in the redosing group for Del Nido. And interleukin levels, these are on the single dose. These are for the repeated dose. Always interleukin levels were higher. That means the inflammatory response was very high in the Del Nido group. And syndecan levels, the early prediction of postoperative organ dysfunction was higher in the Del Nido group and even in the redosing group. And this is the aquaporin level. So in the Del Nido group, the aquaporin response becomes higher, but in the redosing becomes higher, but it cannot compete going up, and then it fails in Del Nido in the second dose, and then becomes cellular edema. How do we understand them? So this is the glycocalyx syndecan levels. Kevin showed them before, but this is the aquaporin level. As you see, this is HDK in the redosing group. So this is the single dose group, redosing group. You don't see any much difference. But here, Del Nido single dose, Del Nido redosing. You see the cellular edema here. As I've told you, aquaporin levels cannot compete with the coming excessive volume in the second dose because the the buffering capacity is not that much strong. This is, of course, a theoretical information I can say. We need to have more data, but this is an initial data. So as a conclusion, redosing is important. For Del Nido, I don't recommend 90 minutes. We are now studying 60 minutes. In my clinical practice, I use 60 minutes for redosing for Del Nido. For HDK, I always use 90. I never need early redosing for these patients. Cost is also, of course, a very much important issue. This is another paper. This paper compares, again, a challenging operation, minimally invasive cardiac surgery, and they look for everything. The cost for blood transfusion, AFib treatment, prolonged ventilation, ICU stay, and everything. So they compared 181 HDK groups versus 181 traditional blood cardioplegia group. And when you check for everything, not the cost of the product. So in the total charges, the Custodiol savings were 13%, open heart 16% or whatever. The only negative difference was in the pharmacy, the cost of the product. How about our data? As I showed you before, we follow up the patients up to 30 minutes, more than 300 patients in each group. So as I told you, when you're operating a simple CABG surgery, like let's say 4 vessel, 3 vessel, whatever, and you use Del Nido, it's certainly much cheaper than HDK. No problem. So there is no significant difference in that kind of simple case with the gross clamp time less than 60 or 90. But in the long term, even those patients had some problems because we showed you before, AFib incidence is 1.5 times more, total event rate is 1.4 times more, and rehospitalization is 2 times more, even in these routine simple cases. In challenging cases, that means when you need redosing, cross clamp time is more than 90 and concomitant surgery or whatever. In the hospital, even we have differences. AFib time, we are comparing, of course, Del Nido versus HDK. So AFib time for Del Nido is 2 times more than HDK. The block is 7 times more. ICU stay is 2 times more. In the 1 month, it becomes much significantly difference. AFib times 4 times, incidence is 4 times more, total unit incidence is 3 times more, and rehospitalization rate is 3 times more. So this is cost. So if you consider all of those costs, I don't think there's any kind of cost difference in the negative way in between 2 single techniques. And then when you wrap up, so details of the single dose. Temperature and pressure is very important. As I told you before, especially for HDK, the recommended time is 7 minutes. Should be at least more than 5 minutes because you have to wait. When you say the hot stop, it doesn't mean anything. You have to wait because it's a kind of ionic change. The intercellular sodium change should be complete. So you need to wait at the end of several minutes or 6 minutes. It's the same story for Del Nido. You have to wait the infusion of everything. So it takes some time, but it's a safe period for myocardial protection. For CABG cases, I always use retrograde because I'm not sure for the even distribution of the cardioplegic solution all over the heart. And now, especially when you're using Del Nido, we have the negative impact of the temperature because let's say if you do CABG at 32, because it was designed for pediatric to use at 28 or 30 or whatever, so it's comparatively warm. So we need to use at least an even distribution to all over the heart. So we always use retrograde cannula. LA venting, we always use to overcome the first initial acute phase volume overload. So we have to vent. It really works very well, especially for control of the sodium levels or lidocaine toxicity for Del Nido. Ultrafiltration is important, and we always use with the single dose techniques. We never have any problem with the any need for correction of the sodium levels. And if we use redosing for Del Nido, we very seldom needs redosing for HDK because usually most of the operations are well done about 90 and 100 minutes. If it's more, so of course we have a redosing for HDK at 90 minutes, but for Del Nido, we always, in our current clinical practice, we redose it at 60 minutes. But in the second redosing of Del Nido, we have the half dose of lidocaine because we also have some kind of unfortunately, bad experiences with the lidocaine toxicity in some kind of patients. So we lower lidocaine dose. So what's the problem with Dalnido? So there are more than 300 formulations now, no standardization. So everybody has a solution that goes Dalnido. So we don't have any information on the safe duration, 90 minutes, 60 minutes, 50 minutes, what? And redosing is not still solved. So even we are doing a new research to compare 90 minutes redosing, 60 minutes redosing, and less. So we need time, and we need more detailed studies to understand the impact of Dalnido in a single technique. So what's my strategy and what's our clinic strategy? So of course, we have every product on the shelf. So we discussed with the patient situation with perfusion, surgeon, anesthesiologist before the operation for the choice of cardioplegia. Of course, our hospital is also based on the financial balance. So for simple cases with good left ventricular function and cross-clamp time expected to be lower than 1 hour, or even poor left ventricular function, we always use blood cardioplegia. For combined cases, good left ventricular function and cross-clamp time should be around 1 hour, which we can use Dalnido cardioplegia for those cases. And we now redose it in every 60 minutes. But for any challenging cases, anything like combined cases with poor left ventricular function, cross-clamp time more than 90 minutes or around 90 minutes, emergency urgent cases, minimally invasive surgery, for those types of cases, we certainly use HDK. But for, of course, maybe financial reasons, we don't use HDK for all cases. But this is our strategy. So this can be modified to the experience or clinical practice of any clinic. But I think the idea is to have everything available so you can choose. So we are also studying now the aspects of, because Custodiol is also used for heart transplantation and storage solution. So we started doing research on the transplantation side. Again, we started with the cellular studies, cell culture studies, to compare Custodiol, UW, and Celsior on the format that we just studied before. As you see here, we just use Custodiol, Celsior, and University of Wisconsin solution versus control. As you see here, after 24 hours in the adult myocardial cell culture, this is Custodiol, it works very well. This is Celsior, very, very much close. And University of Wisconsin, a bit worse, but again, not bad. And this is the control solution. So we also, we will have the data very much soon, I believe. And at the end, I also want to cite some kind of information on the COVID, because we are all dealing with COVID cases, unfortunately. And even we have 4,000 beds, we are now full of COVID patients in the hospital. We have a lot of experience. So it's becoming more and more very much, let's say, we need to modify ourselves for the COVID patients because we cannot escape. So this story will go on maybe more than one or 2 years again. So until now, this is today's results. So more than 20 million cases all over the world, about 750,000 people died. And this is really a very much study, some sad story. So, but the problem is, so we stopped the operations, elective cases, and then we restarted, and we stop again now because of the high incidence of COVID cases in our hospital. So this is a kind of dilemma because this pandemic puts all kind of health services, including us, under a kind of pressure. So we say, okay, we don't do elective cases, but what is an elective patient for cardiac surgery? And then we have now very much challenging patients because, of course, COVID patients is challenging, but non-COVID patients is also challenging because we send them home and they come back with an acute myocardial infarction or becoming worse and worse. So these are also more challenging patients. So this is a very difficult situation for us. So we published guidelines before to handling of those COVID patients. Because when you deal with COVID patients in cardiac surgery, they are hypercoagulable patients. They range different laboratory levels, hyperinflammatory patients. They have many associated disorders, respiratory problems, and difficulty in volume management because maybe you also have your experience, but in my experience, it's the most difficult thing to understand if the patient is over volume or less volume. So you need to give volume or you have to extract volume. This is a very difficult decision for the COVID patients specifically. But as I've told you, if the COVID negative patients, these are usually our urgent cases. So their myocardial function is always very much low, as though they have longer cross-clamp time. So of course, and there's a risk of infection, so we have to use a kind of fast-track surgery. So for cardioplegia choice, we always think to have a kind of ready-to-use something, because it's an urgent operation usually. We have to use some kind of standard safe thing that we trust. And of course, single dose is very important because we're dealing with some additional problems during the operation. We cannot think and cardioplegia as an additional burden, and we need some long-term protection because these are not very much myocardial function, not good patients. So in COVID cases, you have to also have a plan to deal with the cardioplegia. So as an epilogue, so there are, of course, cardioplegic in the world. There are different, despite advances in methods, there are some mechanisms of myocardial protection areas that remain that could benefit from further exploration, especially with single dose techniques. The pathology of the ischemia reperfusion injury is the reason for the postoperative outcome. So we have to find the solution of this. So every surgeon, every perfusionist, every anesthesiologist has an experience. They have their own technique. They have something to trust. So this is why we are using different types of cardioplegias. But still, single dose techniques are becoming more and more popular because they are comfortable. Of course, everybody wants to give single dose and forget everything. But still, we need further research, especially in adult cardiac surgery, including CABG, and to identify the safety of these solutions, to understand which type of better myocardial protection, or our aim is to always give less frequent, but of course at the same time less volume administration to the patient. So it's a time that we still keep on doing more research to understand. So we are asking questions like I did before, and we of course have many more questions to ask again. So we need to speak with the data. Of course, surgeons have experiences. They can, according to my experience, I use this one. Yes, but data is the most important thing, because without any data, you are just another person with an opinion. So you have to put on some data. So this is our aim as a group for the last 25 years. Thank you very much for your attention. Thank you.
Excellent, Dr. Gnaden. So this is Dan Berge again. And so Taylor, if we can have, you can switch on Kevin as well. And Bill for his audio at least. We do have some questions. So just while they're getting set and Kevin's getting back on video, what we'll do is there are several questions that were asked. Just so that everyone's aware, our panelists, some of the questions were asked early. So it looks like some of them were answered in your presentation. However, it wouldn't hurt to, looking at the numbers, they do go up and down. So some may have come in and some may have left. So I will start at the first one. Again, this came in fairly early, but what is the time, and anyone can answer, what is the time between doses, and what if you come off and give protamine? Do you switch to regular cardioplegia?
So okay, go ahead. Maybe Dr. Gnaden, go ahead.
Yeah, okay. So I think I cited some kind of information for Dalnido. Now our usual practice is to redose at 60 minutes. For HDK, I redose at 90 minutes. And this is a very good question. If I use protamine and then needs a cardioplegia, I really use Custodiol cardioplegia, St. Thomas in the second one.
Bill DeCocher, did you have something to add to that? You were jumping in.
Yeah, our clinical experience back at Temple is we would just stick with the custodial HTK when going back on and redosing, just to minimize any confusion or errors from switching from one myocardial protection strategy to another. So I think it's just dependent on the comfort level of your institution and the situation that you're currently in. But we would just, it is safe to go ahead and give another full dose of custodial HTK.
Okay.
Yeah, that what Bill just said, we can confirm that as well. It's almost like a reset, And the important points there, you know, it's the other projects that we're working on, which Professor Ganaden had mentioned, is the idea of aquaporins. And I think it's important to mention that aquaporin proteins, they form from these transmembrane channels, and they are helping the transfer of these water molecules against the osmotic gradients. So through diffusion, the ion channels, substrate transporters, which regularly handle the excessive volume over the cell membrane, and via those aquaporins, they permit that rapid movement of water. So what we're doing now in our research is we're demonstrating that 1/3 of that water movement across the capillary bed into the interstitial space is provided through those aquaporin channels. So that increased expression of those AQP4s, which are specific to the myocardium, that plays an important role in the handling of those volume disturbances during cardiopulmonary bypass. So the point I'm trying to make is, as we further investigate that, we can further confirm that if you, in a situation like that, if you are coming off, if given protamine, need to go back on, you should feel completely comfortable, and then giving another redosing on that. And, you know, with the aquaporins, on the other hand of that, you know, if there's inhibition of those AQP4 levels in that human microvasculature, in those endothelial cells, that induces a high permeability, so you'll have that myocardial edema and the cell lysis occurs. So by limiting that, reducing that, you're going to get a good outcome. So,
excellent, thank you. So that was from Rich. From Samuel Sampson, he asked, what is the latest technology used in cardiovascular surgery? So again, these are early on, so.
latest technology in the
There might be just looking if there's anything new.
Yeah.
It's okay. It's probably not related to this chat, right? So
maybe robotic surgery, I can say.
yeah, yeah. This was from an anonymous attendee. Asked, what kind of blood did you use? Whole blood, or citrated, or?
We are using whole blood for a mixture of cardioplegia. How about you, Kevin?
Is that? Yeah.
Okay. And then what, actually this question was asked a couple of different times, I believe, so I'll just ask it once. And what is your transfusion rate at your hospital?
Nothing. I take it as a personal insult if I have to then go and give a bag of blood, and Sarah and I, we've been fortunate. We've published papers on pediatric blood management programs and adult blood management. So we take that quite seriously. So, and you go back to that group in Nashville with their publications, the blood usage on these single dose. And I think during the course of the bypass, you almost get this luxury of this volume as a perfusionist that you're sitting there where knowing full well that you're going to tend to it. So they've confirmed it in their registry. We've confirmed it in ours, is that, giving blood because of this technique is really nothing that people are doing.
Thank you. This one I know is going to be difficult to answer because it's, I've heard that it varies by hospital and who's doing it, but it was a question of, do you have a cost comparison information for the 3 types of cardioplegic solutions? So blood cardioplegia, Del Nido, and Custodial. And, working for Custodial and Essential, I can tell you it's different by country, but they're so that's going to be a tough one to answer.
Yeah.
Even, for example, I was very much surprised to learn in Germany, the cost of Del Nido is very much close to Custodiol in Germany. This was surprising to me.
Yeah.
Yeah.
Well, and again, do you make it in-house, or do you get somebody like in the US, there's other people that manufacture it for you, so there's going to be an upcharge. Does pharmacy upcharge? Does it go to what department? So but yes.
Dan,
Can Bill jump in and maybe?
yeah, Dan, actually I wanted to jump in real quick because we're
please do.
pressed for time. Just 2 quick questions that I want you both to address here real quick. Was from the same anonymous attendee. That blood question was for Kevin in the in vitro studies. Did you use whole blood or citrated blood?
I didn't hear it. Sarah, did you hear the question?
Yeah, yeah. We always use whole blood.
Okay. And then the last question, and this would be for Dr. Gnaiden. Have you experienced any post-op neuropsychosis in patients that have received multiple doses of HTK custodial? And this is also from an anonymous attendee.
Yes. So we just have prepared the paper, so I know the data very well. So we studied 35 patients in HTK redosing group and 36, I think, in the Del Nido redosing group. So we have 2 cases in Del Nido and 1 case in HTK group that the age is very high, should be around 80 in both groups. So they have some kind of neurological problems, but they were just vanished later within about 2-3 days.
Okay.
Yeah, and there's more questions pouring in, so we'll try to go through them quickly here because we're already into your time, Bill. So I apologize for starting you late, but obviously it's a very, and a lot of them are saying thank you for a lovely presentation. So Val wanted to know what the temperature delivery is for Custodial.
We delivered 4 degrees. So,
Oh, yeah, and I answer that in my presentation.
Yeah.
So I'll take care of it.
Yep.
Yeah.
And yeah, and so Dale is asking, is there a way to get Custodial FDA approved as a cardioplegic solution? And I think, again, Bill, you could probably cover that, but that's a very complicated answer to that one. So we'll go over that one because it will be covered. And then let's see, you did that one, Bill. There's a blood question for Kevin for the in vitro.
I did that one. We did that.
Oh, yeah, you did that one. Sorry.
Yeah. Will this be uploaded somewhere so people then can relog?
Yeah, afterwards it will be, yes. Has anyone used microplegia del nido to avoid possible myocardial edema associated with crystalloid cardioplegia?
So it's not available in our country, microplegia.
Okay.
And I'll
Kevin?
address some of that as well. I'll address some of that in my talk.
Okay. Solomon wants to know del nido in adult blood or crystal, which is better? Okay, so I think that was kind of addressed in yours, Serdar.
Yes.
Okay. Michael wants to know, do you limit your ultrafiltration filtration amounts?
So our target hematocrit is around 25. So we try to do ultrafiltration if it's possible. Of course, we also check for the status of the patient during the ultrafiltration, but our target aim is about 25.
Okay. Bill, you could probably answer this one. Does histidine use a buffer in del nido? What's your opinion on this?
So in the United States, there is no formulary of del nido that uses histidine as the buffer. Custodial HTK is the only myocardial protection solution that does use histidine as a buffer. So I can't comment on use in del nido because I do know that he originally, when he developed the formula, and Dr. Gnaiden can probably attest to this, that he wanted to use histidine as a buffer, but it's not readily available here.
It's
and
expensive.
Very
It's
expensive.
incredibly expensive. Histidine is the reason for the expense of the custodial solution, and it's very difficult to find the solution to adopt in del nido. So it's not easy.
And are you still concerned with ultrafiltration and AKI?
No, not at all. You know, so Serdar and I, we were working on another separate project as far as looking, so everybody that we operate on, if you go ahead and specifically allocate for AKI, it's probably 53% of the people that we operate on are going to fall into that group anyway. So the hemofiltration, that's a whole nother can of worms that we're pursuing.
Okay.
We don't see, specifically through the ultrafiltration process using Custodiol that you're having an increase in these AKI cases.
Can you use lactate rinners instead of plasma light A to prepare del nido?
I mean, I think this speaks to the point in both of those terrific presentations that there are so many different formularies out there. And I guess my recommendation would be you probably could, but you would have to adjust for the pH because obviously
Yeah.
you'd have to add a little extra bicarb.
Are there any experience of postoperative acidosis when using custodial in short surgeries? And then suggestions how to handle it.
Yeah, no, we haven't. I haven't come across any. Should have you?
No, no.
Hmm.
That also depends on the preoperative planning, maybe. It's very rare for me to have early declamping when I use HDK.
Hmm. Yeah, and those clinical findings, that would be a light beacon for us to focus on if people were being acidotic. Yeah.
All right, so there are many more questions pouring in as we're speaking, so it's up to
Yeah.
27.
Is there
So
something we can, Dan, is there a way that we could answer these?
I think so. I think we're going to have to capture them and then
Yeah, I'd be
and then
happy to
maybe
do
at the end if we have time,
Yeah,
or
that'd be great. Sure.
yeah, or what we could always do is put an additional link onto this, because there's looks like there's some great questions, for example, with liver and kidney transplantation and things that are outside of this scope. Let me just look. There's some in the chat here too. So there's a total of
Wonderful.
over 30 here.
That's
So
great.
I'm going to move on, which is amazing. Thank you everybody for your questions. One thing I'm going to also add is there was a lot of emails that were asking about their certificates. So, you know, my understanding for that is the certificates will be, as long as you registered on perfusion.com, those will be sent out to your email address that you registered with. And then, you know, if it's a manual thing that you need, then those will also be prepared, but they may take a little longer, obviously. So hopefully that answers some of those questions. So again, thank you, Professor Ganaden and Dr. McCusker. And hopefully you can stick around if there's some questions at the end we can go through.
Yeah, very nice. Thank you again. We really appreciate you allowing us to do this. I think it's such an important topic at the time, and we've been fortunate and working hard to have all this information available, and thank you for allowing us to give us a forum to share it with everybody. And if you feel free, if you can give out our email addresses, we're happy during this COVID time to reply directly to anyone that wants to email us directly. So we're happy to do that.
Yeah, so Taylor, if you could just add
of
that to a slide at the end, we can put
Yeah,
that
we
on.
usually do that at the slide at the end, but I don't think we did it this time, but
Excellent.
yeah, please people reach out directly. Happy to make new friends and have good conversation.
Excellent. So next up we have, you know, Bill Nicotra. You'll see it under William Nicotra as well. So when you're emailing, and he's the medical science liaison here at Essential Pharmaceuticals. He's a graduate of the Shady Side School of Perfusion in 1987. He's, you know, held positions as the chief of perfusion at the University of North Carolina, Temple, and Union Memorial in Baltimore. So, and then with his clinical experience using custodial HDK, Bill continues to be, you know, a clinical specialist for cardiac surgery. And so today his talk is called Custodial Myocardial Protection and Post-Bypass Recovery. And then following him will be Scott Beckman from Salem, Oregon, and he is a board-certified perfusionist with 30 years of clinical experience. And he's also a graduate of Northeastern and Loma Linda universities. And if you know Scott at all, you will know that he and the cardiac surgeons he works with have a passion for proven best practices and improving patient outcomes. So we're kind of excited for that. And he will, you know, his growing passion for perfusion, and he'll be speaking on a closer look into post-bypass blood recovery. So for people who joined us late, we'll do a Q&A for the two of those together at the end of their presentations. Bill, if you want to take it away.
Great, thanks, Dan. I appreciate that. Again, Bill Nicotra, I am with Essential Pharmaceuticals. I am a clinical perfusionist. For those who may not know me, I've been practicing for 30 years. I spent some time at Carolina, but I did gain most of my experience at Temple University, and practicing for about 24 years prior to going to Temple. It reinforced that you're never too old or never too experienced to learn and to grow. And so I did a lot of learning and growing at my time at Temple, and that's where I gained my clinical experience with Custodial. And in saying that, I'd like to mention that the Custodial HTK is an off-label use for cardioplegia. It is a myocardial protection. It is FDA approved for myocardial protection for organ transplantation. So I do want to make this clear that all of this, from my standpoint, is from my clinical experience in my time at Temple University. So I'm just going to go over quickly almost everything that was already mentioned in those wonderful talks. So there's going to be some redundancy, so I'll move pretty quickly and it will get us back on time. Mike Rackley did go over all of this information, so you know who we are, and a little bit about Custodial, where we came from. So as it was referred to earlier, that this is commonly referred to as Bretschneider's solution. Back in the early 70s, Dr. Bretschneider and Professor Preuss, cardiac surgeon from Germany, who I had the extreme pleasure of many conversations, and hopefully he's on this webinar today, helped develop this formula that we still use today and is tried and true. And when you look at Custodial HTK, here's the composition. It's a hypotonic solution. You can see the sodium level. And when you look at the top 4 ingredients, I refer to those as the arresting components, and the bottom 4 that everybody went over already. These are the protecting components of the actual solution. And as mentioned earlier, the histidine is, there's a tremendous amount of histidine. You can see 198 millimoles. And the reason they're able to accomplish that is because of the hypotonic solution and maintaining the osmolarity of 310 millimoles. So that's why we're able to get 198 millimoles of histidine in this solution. So mechanism of action, Dr. McCusker went over this. So really, I'm just going to fly through it, but as he said, low sodium solution, drawing the sodium out of the extracellular space and thus eliminating enough positive ions to create that action potential. So the heart's just going to stay in an akinetic state. Also mentioned was the low level of potassium. That's in there just to help for a quick spontaneous arrest. Once you have arrest, that delivery of low sodium is going to actually be the ion responsible for keeping that heart akinetic. So I will focus a little bit of attention on protection and go over histidine, which has been mentioned previously already. It is the most important component of Custodial HTK in protecting the heart and keeping it able to protect the heart for up to 2 hours before redosing is required. And we know histidine is an alpha amino acid. It's one of our essential acids, amino acids. And as mentioned earlier, it does a great job of protecting inflamed tissue. And it's a great oxygen reactive scavenger. So it also inhibits the cytokine and growth factors that are involved in tissue damage. And, those are all secondary results to ischemia. So having a high concentration of histidine is an important role in the overall protection of the myocardium. And to demonstrate that, I'm pulling a study, and I got this from Professor Preuss, so thank you, Professor, for that. Here's a study looking at different cardioplegia methods, and if you notice, here's the pH axis, and here's the ischemia down here on the x-axis. And so the top line here is the HTK protected heart, And the second one down here is the St. Thomas. And so when you're looking at zero ischemia right as we're putting the cross clamp on, the cardioplegia level, pH levels are identical. They're all at 7.4 pH. But as soon as you get out to about 30 minutes, the St. Thomas, you notice a precipitous drop in the pH. It's about 7.2 now. And that's typically when, you know, we're starting to think about redosing in typical 4-to-1 St. Thomas cardioplegia just to reset that clock. But when you look at the histidine, the HTK at 30 minutes, we're still right there at about 7.4 pH, just not much of a drop at all. And when you get out to the 60-minute mark, you know, then you really see a difference. You're looking at a pH in the St. Thomas group of about 6.7 pH, and the HTK group is still over 7. We're about 7.2, 7.25. So something that you can draw a conclusion from this is that this is typical 4-to-1 blood cardioplegia, St. Thomas solution, as we all know, which is 4 parts blood. When you're looking at traditional Del Nido in the adult heart, that's only 1 to 4. So you've got 25% of the total solution that you're delivering to the heart has that buffering capacity. So you really are kind of pushing the gun if you go over 60 minutes of redosing. And I think Dr. Gneiden did a good job of sharing that information and that concern. And here's just another slide. And this is study was done at 15 degrees, looking at myocardial lactate levels as they rise in the resulting pH. And the top line is the HTK group, and the bottom line is the St. Thomas. And here's where the critical pH of 6.0 is. And so you notice that the HTK group is nice and stable and pretty much maintains a higher pH with the rising lactate level. And then this is the same study, but done at 25 degrees instead. And look at the precipitous drop in pH as the myocardial lactate rises as compared to the HTK group. So I think there's no more poignant way to describe the effects of histidine as the key component in protecting the hearts. And then here's the control group here of just straight blood, whole blood. And again, you can see that precipitous drop in pH as the lactate rises. So that was histidine, and I know I'm going very quickly because they covered so much today. But tryptophan, it's the anchoring protein. It's our membrane stabilizer, as Kevin mentioned. And it does a great job of facilitating all the ion transports in and out of the intracellular and extracellular space. So when you're arresting the heart will arrest nice and smoothly, and then it will be there available when you take the clamp off and help reintroduce the sodium and calcium ions back in, allowing for what you would typically see a more smooth transition from to sinus rhythm. So that's what tryptophan's there for. And then the ketoglutarate, Dr. Gneiden did go over this. It's the key molecule in the Krebs cycle. It's right there available in the post-ischemic phase. So as soon as you take the clamp off, you're going to have that ketoglutarate available for the myocardium during perfusion. And it's a great nitrogen scavenger as well. So that it's kind of like having the hot shot from the days of old. I used to give hot shots back at Carolina on the majority of our cases before we took the clamp off, and you kind of don't need to with the ketoglutarate available here, ready to go. And then, as mentioned earlier, there's mannitol. It's a pretty high quantity of mannitol in our solution, and it increases the osmotic pressure to reduce myocardial edema. And as purported in the cardiopulmonary bypass third edition, its greatest effect is at the beginning of an ischemic insult. So, what a better time to have a high dose of mannitol than when you're infusing cardioplegia at the very beginning of the case. So we have that high dose of mannitol in there to reduce the myocardial edema. It's a great oxygen-free radical scavenger as well, very well reported. And it does have renal protective and functional improvement qualities when reintroduced systemically into the system. So when you get Custodiol back into your circulation, the reduced potassium levels aren't going to hurt those patients, especially with AKI. So, you know, they're not going to have to take that hit and handle that high level of potassium that we know is just troublesome to deal with from a perfusion perspective. So that's the quick, and I ran through that very quickly. I wanted to spend more time on the actual delivery protocol because some may have not seen this protocol before or understand actually how it works. And I put this slide up here first because with Custodiol HTK, you really could use just a coil in a bucket. There's no manipulation to the current system that you're using. So really there would be no kind of capital or, you know, disposable upcharge to actually utilize the Custodiol HTK. So when you receive Custodiol, it comes cold, so it has to be stored refrigerated at 2 to 10 degrees centigrade. It also is light sensitive, so it has to be treated in a refrigeration system that, you know, somehow is not exposed to light for an extended periods of time. Like I said, a standard ratio set can be used to utilize Custodiol HTK. So if you're using a typical 4-to-1 blood cardioplegia delivery system that's got a bridge in it, you just open the bridge and isolate your blood side and you're ready to go and deliver Custodiol HTK. So then, and there was a question about this, I saw this earlier, then you'll deliver it at 3 to 4 degrees centigrade. And if you're doing this for pediatrics or patients less than 150, you'll calculate a dose of 20 mils per kilogram to a maximum of 2 liters. But for all adults over 50 kilos, I recommend using the just 2-liter initial dose. And then subsequent doses also delivered at 3 to 4 degrees Celsius with a maximum of 1 liter if you're using the pediatric calculation, 10 mils per kilo. So like Kevin mentioned, initially, when we deliver Custodiol HTK, you've got to get that line pressure high enough that you're going to close that aortic valve. It's so important, and that's just common sense, but you know, more so for here. So get the line pressure up, get the valve closed, and as soon as you see electrical arrest, that's when you back off the infusion rate. And as Dr. Ganaid mentioned, the time is so important. So we want to typically give this at like a retrograde rate, for example. And so that retrograde rate would probably produce 80 millimeters of mercury and give that 2 liters for the whole 5 to 6 minutes. And so this is where you have to have that upfront contract with the surgeon because you know, patience is extremely important because the time saved here in arresting the dose is going to be more than made up for single dose technique in redosing if it's necessary. So you need to be patient in the induction dose. And Dr. Gnaiden also mentioned this, and Kevin, you have to avoid distension of the heart. So LV venting, making sure you've got good drainage. It's pretty common sense, but it really is, it is critical when you're delivering cardioplegia. And then, as stated earlier, between 90 and 120 minutes, a subsequent dose might be necessary, and typically recommended is half of the loading dose. So if you're using the pediatric, it's whatever you calculated it will be half of that loading dose, or if you're using the standard adult protocol, then it would be 1 full liter to redose. So, and we talked about this a little bit, continuous hemofiltration and Z-buffing will be necessary if you don't vent the cardioplegia. And when I'm discussing venting it, if you're doing a case where you're bicavally cannulating, the right atrium can be open, and you can just send this to the cell saver or throw away, because it literally is straight crystalloid, and then you won't have to deal with any systemic effects of hemodilution or the hyponatremia that's been mentioned. So these are some clinical benefits that I've experienced utilizing Custodiol HTK, and some of these are also well documented. The first being that the reduced potassium levels, it allows for quick release into the circulation without those harmful side effects of high potassium in the circulation. And then it's low viscosity. This is a straight crystalloid cardioplegia solution. It's not compounded. It's it's delivered as it's been produced. So it's a low viscosity solution, that of water, and it gets to the microvasculature that blood has some difficulties getting to, especially depending on temperature. And so it really allows for rapid cooling of the solution itself, and then resulting myocardium. And if you were to take a look at septal temperatures of a heart that's been well perfused with Custodiol HTK, I would venture to say that you would be somewhere around 10 degrees centigrade after a full dose has been delivered. Already talked about the superior buffering capacity when you compare that to blood. And this is the most important point, and I think Kevin actually talked about this earlier with so many different cocktails and recipes. With Custodiol, there's only one recognized protocol. So you have every surgeon utilizing this cardioplegia the exact same way, every perfusionist. If you're a traveling perfusionist and you go to a new hospital, which can often happen, and they're using Custodiol HTK, there's only one way to do it. So there's no learning curve associated with that. So I think that's really important. No additives are necessary. And I think when you looked at the scope registry and the article that Dr. Gnaiden referenced, and actually Dr. Gnaiden's talk itself, it's most often used in emergencies because it's so easy to just grab from the shelf, hang it, and deliver it. There's no compounding necessary. And the shelf life is 1 year for Custodiol. So you're rarely ever going to throw it away because of an expiration, where typically compounded solutions, as you know, has a very limited shelf life. So that does need to go into account when you're talking about the cost of care. And then retrograde's often unnecessary to protect the heart because of such an even distribution of the solution. There are reasons to use a retrograde, as mentioned earlier, but it's often unnecessary if you have clean coronaries. So some of the challenges, well documented and mentioned: hemodilution. It does make it a little challenging if you have a shorter case and you can't vent the Custodiol to pull off 2 liters of volume if you're using it for a short case. Again, recommend scavenging whenever possible. And then we did talk about this in detail too. Hyponatremia usually resolves without any intervention, and we chose not to use any intervention for the hyponatremia, so it's not necessary. So let's focus and transition quickly here from that to this point of hemodilution, because we are using straight crystalloid cardioplegia, and so the natural tendency is to say, well, hemodilution is going to be a huge issue with this protection strategy. And as Dr. Gnaiden shared with you, and so did Kevin, did a great job. Al Stammers in his group utilizing their scope registry, looking at all the different modalities of myocardial protection. You're looking at the lowest hematocrit on bypass, and all exactly 25, no statistical difference. And lowest total intra-op hematocrit, all 25 in the 25 range, and no statistical difference, excuse me. But you look at the transfusion, same thing. It's not different, but was slightly less in the HTK group. So does that mean, we're done and we shouldn't focus our attention on this any further? Absolutely not. So hemodilution still is an issue, and so much so that recently the Society of Cardiovascular Anesthesiologists and their Clinical Practice Improvement Advisory Committee made some recommendations, because they noted that even in the last decade, with all the advances in blood conservation, that high-risk patients still have a 50% chance of receiving some form of blood products. So there's still a lot of work to be done yet. And some of the recommendations they made for us as perfusionists is minimizing bypass circuits. So minimizing the prime. I think everybody's conscious and doing a very wonderful job with that. Wrapping, I think for the most part, everybody is wrapping. But one of the recommendations in there that I don't think gets enough attention, and is definitely not well studied and needs definitely more attention, is the use of some modified ultrafiltration. Very popular in the pediatric world, but very limited data in the adult world. But some of the data that they referenced in this paper is a study where 573 patients received adult modified ultrafiltration, and they showed reduced postoperative transfusion requirements and reduced pulmonary and neurological complications as well. So there was some merit to that recommendation. And then I pulled another study from the Zacher group in the cardiothoracic surgery, and they looked at 155 patients, and they also noted that it seemed to reduce inflammatory mediators associated with surgery, and it did reduce blood loss and blood transfusion rates, and it improved their cardiac output. So it did have some merit, and I think this is something that still needs to be looked at. And the point of blood management and really kind of focusing on it now during this pandemic, and this was put out probably a day before Sanibel from Perfusion.com, in the Journal of Anesthesia and they said that we need to use common sense principles when looking at patient blood management, because we just don't know the effects of what this is going to do with blood donations and the availability of blood. So we need to do everything we can do to try and manage our patients. And then fast forwarding to July, you've got the Rettori group putting this statement out that they've seen a dramatic decrease in the number of blood donors. This was in France, countrywide, because of the pandemic. And here's a graph showing that severe reduction in blood donations. So this is something that's going to be with us. And again, put out in July from Stanworth at Lancet, they also say that this is an uncertain time, and we just don't know what's going to happen with the reduction in blood donations and actually the loss of critical staff because of illness. So this is all something that's very new to us, ongoing, and requires our attention. So what does that mean? Where do we go from here? Well, as I mentioned, I think that modified ultrafiltration is a way that we can address some of this blood conservation post-bypass, and particularly looking at EMUF, extracorporeal modified ultrafiltration, as a means of trying to reduce blood loss and reduce blood transfusions. What is EMUF? It's basically utilizing ultrafiltration to process your bypass circuit. It's commonly referred to offline MUF. And multi-pass systems are far superior to single pass systems when you're looking at utilizing ultrafiltration of your bypass circuit at the end of the case. I know at Carolina, in my experience at UNC, we did utilize adult modified ultrafiltration, and I think we kind of gave up too early because we weren't seeing significant changes in the patient's hematocrit, but we really didn't dig deep and look at the effects of reducing the inflammatory mediator. So I think it still is something that we need to focus attention on, and I think this does a great job. So again, why should we do this? Well, it does improve the post-bypass hematocrit. It is documented well, and I believe Scott will get into some of this data. It improves your hemostasis. You're saving the patient's viable platelets. So there is, saving the clotting factors is extremely important, as opposed to just sending your entire circuit to the auto transfusion machine. It is the patient's own blood, and I think that this is something where I think the benefit is really can be seen is the volume balance. So typically, you're using one or two schools of thought. You're either overloading the patient with your circuit volume to try and give the patient all the whole blood and back, or you're using the auto transfusion machine to do your bypass circuit to give volume back, and that tends to not be enough. And I think this is a really nice balance between the two, and giving you that perfect amount of volume with all of the preserved platelets and clotting factors. So I think it's important. And with that, I'm going to go ahead and turn it over to Scott Beckman. And Taylor, if you could stop sharing my screen. Or else. Again, I'll take questions after after Scott's too as well, if there are some even more questions coming in about clinical practice.
Okay, so you'll have to, Taylor, you have to unmute Scott, or Scott, you'll have to unmute. There we go.
How's that?
Yep, perfect.
Okay. I just wanted to, again, thank all the participants and to be along in this great group. It's really a privilege to be along with such a intelligent group and all the presentations today. So special thanks to Mr. Radcliffe for letting me be a part of this. And really excited. We, like Dr. McCusker, I'm also coming to you from the ER, or from the cardiac surgery ward, to present something we're pretty excited for. So my goal today will just be to provide a provocative thought to consider for new options for patient outcomes and improving your intraoperative experience with postoperative blood recovery and post-bypass. So at this point, I don't have any disclosures to make. Again, just volunteering our time here today to be part of this group. I wanted to just pull a quick piece from the ethical side of the Society STS group. The surgeons I work with, and many of you online today, you are STS members, and some of the relationships you've had with your patients about not compromising patient care and welfare. Also, you're responsible for lifelong learning. I really enjoyed reading some of the ethical pieces that guide some of you as members. And also just your evidence-based scientific practice focus. I think everyone online is kind of committed to that, and that's why these educational venues is so nice and appropriate.
Scott?
Also for, yeah.
Can you hear me, Scott? If you could share your screen at the bottom, we can't see your slides just yet.
Okay. I'm not seeing that as an option here.
If you move your cursor, you should see at the bottom a green icon next to chat. It says share screen. If you click that.
Taylor, did you make that available?
Um,
There we go, Scott. So just select the screen. So right now we can see your desktop. So just,
okay. How about now?
there we go. So yeah, just start the press.
Okay.
Thank you.
I'll just continue on from this piece, if that's all right. You just still have a view okay? Is that online now?
Yeah.
Okay. Again, just the ethical piece from AMSEC as well, directing our code of accountability to quality as perfusionist and promoting a higher standard, and also to evaluate the equipment that we use, all of us, within cardiac surgery. I think these are good points for all of us to improve and foster great care. One of the age-old trends in auto transfusion, as you know, has been the ultimate plasma loss that is inherent in all of these devices. For us, our patients, the second question that they ask us in pre-surge is, will they be getting any blood products? And we would say, well, we're doing all we can to avoid a transfusion, but then we would roll them down the hall and tolerate liters of wash of their plasma, which we really began to say, well, that's not optimal or ethical care for us. So it's really, is the cup half empty or is the cup half full? And we really have looked at this to really focus on the plasma volume that is being wasted on multiple cardiac surgeries. An example here on estimating plasma volume for males of 1.5 liters per BSA or females 1.4 will give you kind of a rough guide to this. An example of a patient we did recently, it was a small female with a BSA of 1.6, and her plasma volume was a little over 2 liters. So once you do 3 or 4 units of processing of most auto transfusion devices, you've already washed away nearly half of her plasma volume. So clearly, could she handle that or not? You know, that's yet to be seen post-operatively. But if we focus our topic today on process and residual bypass circuit blood, there's really 3 reinfusion methods that we can do, either direct, cell washing, or ultrafiltration. These have all been very well documented and published in different journals. Direct is either while you're still cannulated to just crystalloid chase your entire circuit volume into the patient. But many of these patients, as you know, don't really need a volume challenge. And by doing so, you still have not changed or improved their coagulation status, which once we come off bypass, that really is our end point and goal. Cell washing, you can see as well. You do preserve some hematocrit and platelets and whatnot, but most of it is washed away and sits in your waste bag. The offline muff, as was mentioned, or eMuff, is a way to further concentrate your autologous whole blood and give that back. And you can see some of the numbers here on this table. The crit is approaching 50% or more. Platelet counts are substantial. Fibrinogen is very prolific in this volume, and also the percent of clotting factors that are present there and concentrated really impact the postoperative period and the intraop optimal coagulation. So clearly, pretty well-defined, well-understood means by your surgeons and perfusionists as far as methods out there that can be used. I thought it was pretty appropriate that just hot off the press this month is a group with McNair and elsewhere in Canada that just did a phenomenal job. This is from the Annals of Thoracic Surgery, showing that looking at online muff where they're staying cannulated and heparinized and taking some amount of time to take off some significant volume versus the offline muff using capability in that direction, or just typically cell washing your entire circuit volume. And you can see here underlined in red is the offline muff was associated with the least frequent transfusions. So very great work done by this group, which really highlighted these maneuvers for minimizing transfusions when this option is given. Being that I worked for specialty care, the administration and quality department was very eager to provide anything they could. And this slide is representing a little bit of historical data, but showing in this population of over 30,000 all-comers for their group across the country, they were showing that on average, they were giving back a little over 700 mils for standard open hearts. And thereby, we all know that if you're giving that much volume back to a patient, you've lost 2 to 3 times that volume in plasma volume, assuming a normal or even low hematocrit. So with this information, specialty care has already been promoting best modalities and best care, and now almost 18% or so of specialty care bypass cases are now utilizing ultrafiltration in some form to process their end bypass blood and MUF technique, which is a great trend, and we hope to see this number as average coming down in future periods of time. And this is kind of one of the reasons. This is a couple cases that were done here at Salem, two different cases pictured left to right, showing you that this trend has really caught the eye of a lot of clinicians and also many vendors, cell washer devices. You can see at the end of a typical open heart here, only 48 cc's on this patient and 71 were attributed to cell washing, and over 901 liter were giving back through the ultrafiltration device and the hemobag system, which we'll cover shortly. So there's many pictures like this that we have at our program, which some of these vendors are saying, wow, what are we missing here? And I think the take-home message is it is the concentration of whole blood that's really proving to be some benefit for patients. One of my frustrations is, why have we had such a love affair with one blood cell and it happens to be red, and we simply tolerate and discard so much of the other patient's viable product that can be used for their ultimate recovery. This slide you may have seen before, it's been presented before, but just to simply illustrate, we know that when you have an open heart patient on the table, you have a primed bypass circuit, usually with crystalloid. You then go on bypass, they become one, homogeneously mixed, same one circuit, one patient, one same volume. Then once we come off bypass and separate from bypass, we have two separate circuits, now exactly the same blood volume. But now the bypass circuit has whole blood in it.
Hey, Scott.
And I think
I'm sorry,
yeah.
so sorry to interrupt you. I know you're doing a great job. We see a split screen, and so your main presentation slide is a little too small.
Okay.
If you can increase that for us, that would be very helpful.
I'm not sure how to do that. Let me just try this by I'm not sure how to do it at this point. Do you think we can sneak by with this or not?
Yeah, if this is difficulty, I think it's in like a display setting, but yeah, I don't typically use this setting. All right, thank you.
Okay. So at this point, I'm just talking about the diffusing the paradigm that bypass blood is somehow tainted or should be washed. At this point, we're able to really try to prove this. This is the same volume that we're trying to reinfuse the patient, but now we can better it by ultrafiltration. This is a picture of a perfusionist motorcycle I'd seen with these license plates that mentioned off bypass, and it really kind of made me think about a perfusion challenge I'd like to offer you today for the perfusionist is, can you make the post bypass blood recovery the most influential for intermediate and intra-op and post-operative period? Meaning, can you make the time immediately post-bypass even more important to this patient as it was when you were on bypass? And I think this will show that the whole blood salvaging offers perfusionists a new role in optimizing hemostasis and homeostasis for the hours after bypass. The universal methods to maintain and improve coagulation, this has kind of been well talked about today from normothermia, surgical integrity, factor preservation, biopassive codas, even mini circuits. But ultrafiltration has really been the one piece that's emerging as the most significant contributor for reducing allogenic blood component. And this has been a Class 1A recommendation by the STS and also the Society of Anesthesia in these guidelines. And it's really interesting to note that when a Class 1A recommendation comes out, for me, it always makes me think, well, am I really doing what's optimal, and should I mend my ways to comply? And a Class 1A recommendation, as you well know, for those of you online, show that it is something that should be strongly recommended and considered unless there's some other compelling rationale for some other approach to consideration for clinical use. As far as hemoconcentration, we know that this is a powerful tool that we have to preserve plasma proteins and to get some of these benefits that are listed here with the removal of some drugs, whether they be, once some of these drugs are bound to platelets, we know that's an irreversible bond, but plasma levels can also be reduced, preserving hematocrit and platelets, also the reduced inflammation or anaphylaxis to reduce that with complement, interleukins. Some of the presenters have talked about some of these reperfusion injury sequelae that happens. Ultrafiltration can help reduce some of that incidence and give us some benefit for that. Also reducing platelet activation factor. It's been well published that way, but Nyack and others showed that platelets having aggregation still exists in the residual volume inside a bypass circuit once separated from bypass. So interesting to show that plasma proteins also have action and presence with this same view. So really showing the powerful effect that we can have for our patients. This slide is indicating from 2019 nationwide STS post-op renal failure. Some comments were made about AKI, and that's an interest of mine as well, to really disprove the notion that to use ultrafiltration on bypass, that it really is not hurting our patients and only helping. This slide is really showing that almost 22% of our total open hearts that you and I are handling across the country have some sort of post-op renal complication that happens because they're coming to us sicker. As we heard, their STS scores are higher, and we really should use that to modify what we potentially do in CT surgery. This slide I hope you can see with the split screen. I apologize for that. But this is a hospital I have visited who before were using cell washing, and they've offered some of their STS findings from the last year that their final volume, that they're now using whole blood ultrafiltration. These are isolated bypass cabbage cases that presented here. So here we have intra-op blood product use. You can see this is down less than 10% compared to like hospitals and the STS as a whole. The intra-op and post-op product use. It's nice sometimes to get a post-op view of our impact on blood usage. You're also seeing that the graphic trend is lower for this, again, beating like hospitals and STS as a whole. Total ICU time. These patients, again, they have 98% usage of the hemobag system at their whole blood concentration efforts. You can see also that their ICU time, greater than 24 hours, is much reduced by the usage of their total program efforts here. Also, renal failure complications, they see no increase in this trend, showing that these also are favorable maneuvers that they're doing in surgery. This one here says the post-op length of stay, less than 6 days. So a higher number on the left here is better, lower is worse. So they're showing that a higher percentage of the patients are leaving in less than 6 days for these bypass cabbage cases. And also the post-op length of stay greater than 14. So a lower number here is better, showing that this particular hospital is showing some benefit in their total care for even their sicker patients that have this problem. Hope that slide is clear. Glycocalyx was mentioned earlier by Dr. McCusker and others. I really enjoyed those comments. The glycocalyx, I talked to Perfusion some time ago and they didn't even know what that was. So I really think that it's things that we've done now are focusing more on the microvasculature, etc. But the glycocalyx, as most of you know, is a tiny hair-like structure that act as a Teflon-like coating throughout the vascula that preserves endothelium from white blood cell and platelet adhesion. Here you can see normal electron microscope view of that. And here is one where it's beginning to be degraded and hampered. This is just a graphic representation of the same thing. Here you can see the vascular lumen here. The glycocalyx is imaged here. And we know that from shear forces, inflammation, ischemia, hemodilution, these type of things break down this glycocalyx. Again, like I said, so it attracts white blood cells and platelets, things not good for inflammation processes. Albumin, interesting enough, albumin is shown in recent literature to be the key protein that helps preserve glycocalyx. So I think as perfusionists, the more we can keep this in mind, I know it's subclinical, but it is happening and it is very important for our patients. Some of the key plasma proteins of oncotic pressure is the glycocalyx and the percent of albumin that's preserved. You can see the albumin, almost 80% of it makes up the total oncotic pressure. And immunoglobulins make up another 21%. Again, focusing the effort that the more you can do for these patients to preserve albumin and maybe administer it if it's low is a great move. Sewing perfusions add albumin on bypass, and then they're primed to wash it away, either with ATS, same with some of the drugs given. These are our tools to help prevent anasarca and overall edema. This is a great journal article that just came out recently as well. And their conclusion was the presence of post-op hypoalbumin can, if it's low, can impact your long-term outcomes and really hamper efforts. But here they're showing that albumin level 3.5 or greater is very important for the preservation of long-term recovery after surgery. The complete blood recovery, very important. This is kind of the work that we're talking about with some of the options. You know, as we've talked before, we are avoiding just going for just the red cells, but now focusing on all these other amounts of whole blood that are key for preservation for our recovery and our patients' outcomes. The hemobag, as you know, here's a great picture of it. You've seen this as well. I hope most of the people online have at least been exposed to this, heard about it, seen it in some of the articles that have been written or at meetings perhaps, but specifically made for perfusions to recover their bypass blood volume in a multi-pass ultrafiltration way. It's also one that's in compliance with the JW population. They also are much encouraged by its usage for their patients. Graphically represented here, you can see that what you're really doing with this, for those of you who haven't used it before, you're really crystalloid chasing your entire circuit volume into this device, usually backed by the perfusionist. It's then in a multi-pass way, hemoconcentrated to a small mini circuit, same hemoconcentrator you're using on bypass, and you're shooting for half its starting volume or at least doubling your hematocrit in this volume. And this is where the whole blood is recovered. Once this is re-administered by the anesthesiologist, another 50 protamine can be given to reverse this, another 5 cc's of protamine. So I hope that's clear. We can recover that more if people have questions on that. But for many circuit recovery, the hemobag device is really an industry changer as far as its abilities. At my hospital here, our laboratory was very helpful in looking at these values over 500 patients. The average volume was 800. The hematocrit was 49%. You can see these counts here, the platelets, fibrinogen at 451, total protein and albumin preserved. This is very well documented in a lot of our work here with our lab. And factors 7, 9, 10, and 13 also had a huge increase in some of the random samples. Those are tests we have to actually do outside the hospital. They're more costly. So we did those on a few, but the trend and index was quite a huge increase in that. So substantial. This may be the power slide of the deck here for my sample, just showing the importance of substantial volume and whole blood recovery. This is a study that we did at my hospital showing that once we had separated from bypass, had given protamine, these pre-levels, you can see they may be a little bit small on your screen, but showing an INR of almost 1.7, 1.9 in some cases. And then post-hemobag infusion and the additional protamine, these were levels inside patients at that time, cardiac surgery pre and post administration. We saw some great recovery. Anytime you can drop an INR from 1.7 to 1.4 or gain a 0.3 on that scale is substantial. And if you're doing that without giving blood products, that's even better for impressive results. Great work by Dr. Ross and the rest of the group here on determining these values that were important for showing the value for blood recovery. This slide's a little busy, I apologize, but it shows a relationship of clotting factors and PT that's exponential. Dazik and others showed this. But when you take a patient here at the red arrow, this is where we come off bypass. If you just directly reinfuse this volume, that's great, but it won't show you any increase in coagulation until you concentrate the whole blood and give it back. So the use of the hemobag or whole blood ultrafiltration moves you to a left shift, which is better coagulation for these patients. Impressive results to see the kind of recovery, percent of the factors that we're recovering for these patients. This I give the special thanks to Mercy Hospital and their staff at University of Pittsburgh. This is a perfusion article journal that was presented here showing that also the views of multi-centered work that showed that further improved work with whole blood concentration post-bypass improved coagulations, not just at one hospital, but at several centers for their use. I wanted to show you this slide as well, showing that the blood bank equivalent of fibrinogen volume, we're finding that with our usage here that one average hemobag volume of about 800 cc's is equivalent to 3.7 units of FFP if you're looking at only fibrinogen volume, fibrinogen concentration comparison. We know FFP has other products in it, but the fibrinogen alone, with some of the work that Dr. Wagner's done, showing that if you have a low platelet count and yet you have a high fibrinogen, you can usually get by without a transfusion of platelets because of the high fibrinogen level. And this also was verified by Salem Health Laboratories. So an impressive average comparison of hemobag volume and FFP. Here I just want to show you two quick case reports. You can see this on a 60-year-old CABG patient. After a bypass, 1150 of concentrated whole blood was reinfused. That was our end volume that was given back. It's at 430, fibrinogen 972. Very impressive recovered fibrinogen. The lab actually called us to see if we had given them a wrong sample. Just some great total protein recovery. And you see here post-op bleeding at only 290, ICU stay less than 24 hours and no products. This also, we've had patients come to us from Yuma, Arizona and other places wanting to be done in Salem with the use of the hemobag as part of the protocol. Patients are coming so much more educated and informed of what they can have available to do. One last case report I'd like to show you. This is a 71-year-old female, our first case that we ever did, a circ arrest at 38 minutes at 18 degrees, which resulted in these findings with no blood products given. This was a value after the hemobag panel was given, a crit of 30 and INR of 1.5. You can see some of the values of length of stay and low vent times. And again, things were said earlier about the osmotic pressure, oncotic pressure showing importance for that recovery. I hope some of these slides have been helpful for you in addressing this. I'll end with this slide. I just wanted to tell you about the Swilken Bridge. It was built over 700 years ago. This is the old course at St. Andrews for some of you golfers. This is so shepherds could move their flocks across it and safely to the other side. I would also say to you, some greats of the game have gone through, but even for you, as you shuttle your patients and bridge them to post-bypass into the post-operative period, you do what you can to better their outcomes and improve patient care. So thank you very much for your time.
Thank you, Scott. That was awesome. That was a great presentation. Bill as well. You know, there's been such a great number of questions. You know, I've asked Bill to jump on here as well. I can see that he's unmuted, so that's great. So what we're going to do is, Taylor, yes, if you want to put that slide back up, we've listed everybody's emails there, so that if you have any questions directly for them, you can ask them. There are 42 questions in the question and answer, so we'll never get to all of them. So what we plan on doing is creating a document with those questions and answers. That'll obviously take some time, and we will send that out to everybody that registered. I think that's the easiest way to answer the questions given the time constraints. But having said that, Bill, if you want to start with a few questions for Scott right now, and then and then afterwards, if Kevin and Serdar are still available, then we might be able to get to some more that were missed there as well. Thanks again, everyone.
Sure. So with the hemobag and EMUF, and this is kind of for both of us, but I'll defer to you as the expert, Scott. How effective is that process of removing heparin, and how do you handle heparin?
Sure, yeah. Obviously, its use requires heparin. This is heparinized blood since it's post-bypass. It still is in the circuit. It is required for that. Hemoconcentration moves a small amount, I would say, but not near enough to consider it normal blood to reinfuse without it. So once the heparin is in that, it needs to be reversed once it's infused into the patient. It should not be reversed while in the hemobag. It's only after infusion into the patient. And then typically, as per the instructions for use, another 5 cc's of protamines works very well for that.
All right, great. Another question that just popped in about that. After you come off, how long does it take to complete this process? And are you still using the cell saver, or have you totally eliminated it?
Yeah.
This is
So
from
we've
Rich.
come close on a few cases to eliminating the cell saver use, just because you saw the cost benefit ratio to have a cell saver there when there's less than 100 cc's on adults, again, is not best utilizing the cost. But as far as the time, it's about 6 to 8 minutes, and I would really stress it's really best with an adult hemoconcentrator. The pediatric ones are just too small in surface area to really help you get this in amount of time that most anesthesiologists can wait. So adult hemoconcentrators with even some slight vacuum is very helpful in cutting that time down to well under 10 minutes. 6 to 8 is usually our average for an experienced team and its usage.
Mm-hmm. Another great question for you, Scott. This comes from Paul. He said that 1,100 is substantial amount of volume to give. Are you employing any type of hemoconcentration while on pump so that there's not as much post-pump volume?
That's a great question, Paul. Yeah, we do use ultrafiltration on bypass. We're usually Z-buffing for most of the case. The anesthesia volume given in cases may vary from provider to provider, so it's not uncommon for us to have, and our circuit prime is around 700 to 800 cc prime volume. But some of these patients, as you know, are coming to us in failure or fluid overloaded. Those patients we are treated. We are big fans of zero balance ultrafiltration, and we do utilize that, especially with our use of custodial and saline replacement. We'd rather actually get the sodiums back to a normal level, but we don't treat that per se, but that is our volume replacement protocol.
Great. All right, this one is from Rich, and this one is kind of directed towards my talk, so I'll take this one. He said when they started using Custodiol at their hospital, the surgeon had problems visualizing the coronaries. He asked if there's any way to add color to the Custodial bag, so we ended up putting a little bit of tinge of blood in, and that worked great. Is anybody else experiencing that? And I will tell you, with my experience across the country, because I do go and visit quite a few centers, that Custodial is a crystalloid cardioplegia, and naturally it will wash out all of the red cells in the coronary system, and it can make it difficult to identify targets. So marking them clearly prior to and actually adding like a tinge to the back basin and using the syringe method is a great way to get over that obstacle. So that's a great question, and yes, others have experienced it, and you're doing what the common practice is out there.
So Bill, I see some questions in regards, and one was also from Rich, I assume the same Rich, about the cost of the hemo bag and after you've come off, how long does it take and things like that, technical questions. So one thing I can say to Rich is you can get a sample, so that's obviously free, and then we can go from there. Bill, anything to add to that? Come
No.
to you for those for cost and everything, right?
Right. I'm sorry, Dan, and I was reading another question, so I didn't.
Okay, go ahead. Sorry.
Last part of your. Paul has asked an important question. That's if Dr. Gneiden and McCusker are still on, are they able to answer questions? And if not, I can answer this one with my experience. I don't see them on, so I will go ahead and tackle this one. Do you administer warm blood reperfusates or hot shots before you remove the cross clamp in your Del Nido and Custodial arrested hearts? And I can tell you that there is a mixed practice. We did at Temple give a hot shot for some of our cases that were challenging, and we had extended arrest times, but it wasn't it wasn't on every case. So it is absolutely permissible, and you're free to do so. Use a reperfusate or a hot shot. All right, Dan.
Bill, I'm here. So,
Oh, great.
So in the last, let's say, 10 patients, we also try hot shot for Del Nido at the end of the operation. The aim was to sweep off the, let's say, the end products inside the coronary. And it really worked well. So we're now using the redosing at 60 minutes and at the end, a hot shot for Del Nido only.
Great. What is, Dr. Ganai, you can answer this question. What is your preferred method of treating hyponatremia if and when you do treat? Would it be bicarb or would it be saline? What would be your choice of?
Well, I usually wait a long time to recover. So usually the patient recovers by himself. So I very seldomly need to correct the sodium levels, and I usually use bicarbonate.
Great. I will field this question, and I'll destroy the name if I try it. It's Fawzia. I'm sorry, I can't pronounce your name. But the question was use in custodial for other organ preservation. And I probably will just tee up my next talk that will be coming up here in the future, that you can utilize custodial, for example, to protect the kidney when you isolate the kidneys for thoracic aneurysm repairs. There's a great paper out there to address exactly how to do that. So that is one of the ways that you can use custodial other than for myocardial preservation. And then, of course, it is FDA approved here in the United States to use for preserving organs in transplantations for liver, kidney, heart, not so much lung. Lung transplant is very seldomly used for lung, but for heart, liver, and kidney and pancreas, absolutely well adopted and utilized. Dan, did you see any other questions that need some attention?
Yeah, there was one for you, Bill, about how effective is eMuff in removing heparin.
I think that's the one I kind of punted to Scott.
Okay, sorry, I didn't see that.
No, that's okay. But typically, unbound heparin obviously will be removed, and then you still do need to use. You'll still need to actually use some more protamine to counteract, as you would with any kind of whole blood post bypass conservation techniques.
Bill?
Yeah.
Oh yeah, good. Yeah, you bring up a good point. We're still in the old school fashion, couple of cases where we'll go ahead and pull in an old Kobe positive displacement pump, and we will perfuse the kidneys on some of those thoracic cases. So that's an old school mentality of delivering at 4 degrees, take some lactated ringes, put some Solumedrol in there, and then go ahead and isolate them. And you bring up a great point where custodial is, as an organ preservation solution, it works very well there.
Yeah, Mona asked about how can I store it again if I didn't use all the amount. I assume it's in regards to custodial, so it's not. You can't, use it and then store it, but typically you're using a full 2 liters per adult, and it does come in 1 liter bags. So if you're doing, peds or something which has a different delivery protocol, it does come in smaller amounts.
I can jump in there too, Dan. As long as you haven't spiked it, you can actually restore it for another case, because it really hasn't been exposed to any kind of extreme temperature or an extended period of light that would disturb the chemicals within the composition. So it's okay to re-refrigerate that and use that bag that you did not spike for another case.
Bill, someone also asked about how to avoid, with cardioplegia, how to avoid vasoplasia. Did that get addressed anywhere?
I think the question was which one produces the least amount.
Yeah,
And
yes.
I don't think I'm qualified to answer that one because of I haven't done any kind of side-by-side studies to look at that. That may be something Dr. Gnaiden can answer, and so I'll let him try and answer that now. And if not, we can.
We usually also, it's not a very frequent reaction, and it's becoming more and more popular now, the topic of vasoplegia in cardiac surgery. And we always have methylene blue with us, the IV form. So I don't see any difference in between, and it's not very much frequent reaction. So whenever I see a significant vasoplegia, we always use methylene blue infusion.
Elaine just asked if there was any studies comparing UW to HTK solution. There are years of studies and probably 1,000 studies on HTK solution, custodial HTK, I should say, clarify, and then UW comparing. So if that's in solid organs you're referring to, heart, liver, pancreas, there are quite a few. Simple searches will find them, but you have our emails. You can reach out to. Probably the best is to Bill Nicotra there, and we can narrow it down to which type of organ you're looking for, and we can put you in the right direction. There was a question about neonate patients and dosing. We can always provide you with with our package insert that has that information on it for custodial. There was questions about custodial. If a patient has AI with a protocol, do you follow retrograde only? That's probably a good one for you, Bill.
I think one that I can handle, and also I believe the other panelist can as well. So there are two schools of thought in handling wide open AI and arresting protocols with custodial. You could either do an arresting retrograde dose, roughly about 1 liter, and then open the aorta and give subsequent doses 5 and 5 down the right and left coronary arteries. That's probably the most widely accepted protocol, but then there are others that just clamp open and give direct osteal perfusion down the left and right. And I've seen intermittent use of 5, 5, 5, and 5 just to make sure to get uniform cooling of the myocardium during delivery in that particular technique if you're utilizing direct coronary perfusion at the very beginning of the infusion. So that's my clinical experience. I can defer to Dr. Gnaiden as well, since he's probably got some protocols.
We also use the same. We use retrograde to stop the heart and then open aorta and then use the coronary cannulation.
Well, I think that's it, Bill. Do you, scrolling through, again, there's 46, so I think that's a testament to how, well appreciated the talks were. But do you see any others that jump out at you that could be answered right away?
No, and they're still coming in. So I think this is probably a good point because we only have a couple minutes left of the actual airtime, and so I don't want to start a question and not finish it. So we will do exactly what you expressed, Dan, and get these all answered individually.
Yeah, and so again, thank you to all panelists. It's been an amazing experience. This was our first one, as Mr. Ackley had mentioned at the beginning, first of many. And so these are trialing times, and we have attending this. We're well over 200 that were here, and I know some will be watching online afterwards on YouTube. Will be posted, and others that we can't see. So well attended. There was over I think there was 10 or 12 countries represented. I myself am in Canada. I know we're spread all over Scotts and Salem, Oregon. Bill, you're in Pittsburgh. You know, as Dr. Ganaydin had mentioned, he's in Turkey, and Kevin being in New York. So these kind of things might be the way of the future or the new normal. Who knows? But you know, obviously, you were the first for us, and we really appreciate the questions, and they're all great. So thank you very much.
Thanks, guys.
Thanks, everybody.
Thank you.
Be safe, everyone. Thank you.
Thank you.